Okay, good afternoon, everyone, and welcome. I really appreciate your support for this joint symposium with the IEC and the IPC. Many thanks to the people who made it happen, the secretariats, in both IPC and the IEC, people who've worked so hard to make this happen. I also want to thank Amy Paller, who I think is going to arrive a little later, and Yale Yashim, who unfortunately can't be here just for really geopolitical kind of travel reasons, unfortunately. But they had a huge amount of work and effort into designing this program, and I just want to acknowledge them right up at the front before we start. So this is the QR code. You can get the program, speaker biographies, and so on by scanning the QR code. I'm going to give a few remarks about the IEC, and then Bruce is going to follow with the IPC, and the code will appear again at the end of Bruce's remarks. So you get a second chance if you don't have the phone ready at the moment. There's complimentary Wi-Fi as well for anyone who needs it. No password required. So this afternoon's session is psoriasis or dermatitis, where boundaries blur and treatments flip the script. And you'll see what we mean by that as we go through the program. Briefly, a welcome from the International Eczema Council, of which I'm currently president. This will be recorded and posted on both websites. Any IEC questions, you've got the email here. If you want to join the IEC, contact the other Alan Stiles at his address. You can contact me too, but I'll just... The IEC is now, we're very much following in the footsteps of the IPC, learning a lot. This is our 11th year in business now. We're now in 38 countries, 187 counsellors and associates across 6 regions. And we're looking to deepen that, in areas like Africa, Eastern Europe, Asia, South America. So if you know talented people who want to be interested, who are interested, please let us know. You can apply to be a member if you're a dermatologist or an allergist or a PhD. These are our mission, vision, anthem, and values. I think we'll just read out the vision here, and that's really to transform the lives of people living with atopic dermatitis through promoting research and education. We've been generously sponsored, and the sponsorship has kept us alive for 11 years, and we're super grateful to that and dependent on it, and we just want to acknowledge all of our sponsors who are here today. You can connect with us on social media. Probably LinkedIn's our major social media platform, but we also have a lot of videos now on YouTube, over 100 hours of content free for everybody that you can watch, and today's session will also be on that. I'm going to pass over to Bruce, who's my co-chair for today.
So thank you, Alan, and it's also my pleasure to be a part of this program. It's kind of a natural marriage to have the IPC and the IEC do a symposium of this nature, because Ken and I always discuss, like, if you treat a lot of psoriasis, you treat a lot of eczema and vice versa. It's like, this is not a hard transition. And in this instance, if you treat a lot of psoriasis, you might encounter some eczema and vice versa. So it makes sense to have a discussion about these phenomena. I serve as the IPC president of an institution I've been a part of for almost 2 decades, one way or another. And we too are reliant and extremely thankful for our sponsors who are our lifeblood and allow us to have programs of this nature. And really they stand at an arm's length, allowing us to have a program that is unbiased and very educational. And we have a mission and a vision, and like the IEC, we're really about improving the health and well-being of people with psoriasis worldwide. And we do that through education, research, and advocacy. And we really would like to create a world that's free of the burden of psoriasis, where everyone has access to the best available care, and the opportunity to live a healthy, fulfilling life. Our professional network, when I look at this map, I think we got all the continents except Antarctica. If you are from Antarctica, please send an email to Christy, and you will then complete our geographic spread around the world. But seriously, we have 233 board members, counselors, and junior counselors in 50 countries. And And that map in and of itself is quite impressive. And we're always trying to grow our representation everywhere. So again, if you have any interest and you feel like you should be a part of the IPC, you can email us. Go to our website. And these are our areas of focus. Access, research, collaboration, education is a big thing we do, of course, as evidenced by this symposium. Regional delivered education as well and programs, and then expanding our global network. And then, as Alan described for IEC, we have we have a lot of educational material on the web. So you can look at YouTube, for example, and find a lot. I've made videos for IPC, and I don't remember, but my dad will say, I just watched your video on this. It was like 8 years ago on YouTube, so they're there. And then we have symposia that are worldwide. They're global symposia, one attached to the SID meeting, the ESDR meeting in Germany, the EADV that'll be in Vienna this year. And you can see various topics are covered. And then we have regional meetings, so for example, one in Buenos Aires. And you can scan that QR code if you would like to stay connected on all the social media sites. Varyingly, we are on these social media sites and always growing our reach through social media. And then to scan the QR code to get the program guide, you get today's agenda and the biographies of the speakers. All right, and then Alan mentioned the chairs. We really have to credit Yael and Amy for putting together the lion's share of the agenda and the educational product you're about to get. So we can't do any of these things without the hard work of our counselors and board members. So to start, we're going to have Dr. Jason Hawks come to the stage. He is a board-certified dermatologist. He's the co-owner and chief scientific officer and investigator at the Oregon Medical Research Center in Portland, Oregon. He's a counselor in the IPC. He's on the medical board and scientific advisory committee of the NPF, National Psoriasis Foundation. He's also an NIH-funded investigator, nationally recognized speaker, gets a lot of teaching awards. Including he got the Exceptional Teacher of the Year and NPF Outstanding Educator in Psoriatic Disease. So Jason's going to talk about the clinical presentation of eczematous reactions in patients receiving treatments for psoriasis.
Thank you, Bruce, and thank you for the IPC and the International Eczema Council for putting this together. And I'll have the pleasure of presenting with Ken Gordon, where we're going to kind of set up the framework for looking at this. We're going to call it a switch necessarily, but this shift clinically by our eye from the psoriasis patients receiving psoriasis therapies, moving towards more of an eczematous eruption. Actually, Andrew did a great job in setting up some of that, and I won't spend time on some of that overlap. These are my disclosures here. So what I want to go through is a little bit of what we're seeing in the literature. So I think clinically, we have a good idea of what these cases look like. We've had some of these patients that have been challenging, but I want to go through what are we learning about in terms of the literature suggesting mechanisms. Do we understand this pathway? But also some of the confounding variables, which Andrew did hint at. So I'll say disclaimer, I don't have a satisfying explanation for these observations because the science isn't there yet, but we're learning from these cases to start answering questions about how we might be able to get at the mechanisms, because we do need to understand this in terms of both diagnostic recognition, but also therapeutic management. So what are we talking about, just to set the stage? We're really talking about these psoriasis patients treated for psoriasis who then have a change in their initial morphologic features, right? We're not going to necessarily apply a certain terminology to that, but the idea is that they look one way, you treat them, and it looks different after that. In the literature, there's a lot of mixed terminology, not surprising as this is relatively new, and I think part of this shift to being new is the fact that we've moved from broader acting agents, cyclosporin, methotrexate, for example, phototherapy. Now we've moved into very targeted therapies on key pathways driving diseases. So it's not surprising that this is actually coming out now as those therapies have gotten more targeted and a little bit better. But these are some of the reactions. You'll see PE abbreviated in the literature. I'll use that in the presentation. It'll paradoxical eczema, paradoxical eczematous reactions, biologic-induced paradoxical eczema reaction, which implies that drugs definitely causing it, which I would say is a far reach right now based on what we know. And then, of course, this phenotype or class switching. Class switching, I'll tell you some of the challenges with that terminology, but definitely a phenotype switch, right? That's what we're seeing clinically. It looks different. So the observations are real. There's no doubt across the board we're seeing these observations. The question is the mechanism clear? And the answer is it's not really clear yet. So we're just barely scratching the surface. But what we know from some of the literature is that the prevalence of this is less than 5%, somewhere in the 2 to 4%. So it's not a majority of patients. It's a small number. And the question is, well, who are these patients? It's less than 5%. And what can we learn about when they present? Are there clues that might tip us off? And I'll give you a little bit of that. I won't spend too much time here for challenge 1, the initial diagnosis, but Andrew did a great job in setting this up. This was one of my cases, sent to me from a very good academic center, seen multiple dermatologists, biopsied multiple times, was sent to me with a diagnosis of recalcitrant plaque psoriasis. And when I talked to this patient, the thing that was striking is he said, no matter how long I use clobetasol on any single lesion, it doesn't change at all, which is really interesting. But look at this up in the upper left-hand corner. He's had this central clearing, which doesn't have it's not really a feature we see with psoriasis, not untreated psoriasis. So this patient ended up having a different diagnosis entirely, but the point was, clinically it looked like plaque psoriasis in areas, but it didn't follow the treatment response pattern at all. This patient ended up having cutaneous T-cell lymphoma, or MF. And so I think that one confounder we have to consider for these cases is that there are probably a substantial portion of them that have been misdiagnosed from the beginning. So here are some good examples. So this nummular eczema, misdiagnosis psoriasis. We got MF case. I showed you a CTCL. This one on the face was basically a seb-derm overlap, SIBO psoriasis that had pretty classic CTCL when they had the workup. This is a case on the left, plaque psoriasis, with a patient, one of my colleagues at the academic center who had treated this patient as eczema because of the lichenification you can see right there on the knee. You can see where I did the biopsy. Actually just had plaque psoriasis pretty through and through, had a strong family history. SCLE, stasis dermatitis. So I think the point is that this is still a clinical diagnosis, and this creates some of the confounding that we might see. These patients have, as Andrew mentioned, it's a spectrum. There's overlapping clinical features, and most importantly, there's no definitive biomarkers. We still don't have a diagnostic test or any commercially available testing that can differentiate between these inflammatory entities. So we're really relying on the clinical skills of that practitioner to make the initial diagnosis. And one important point is that biopsies cannot reproducibly distinguish between psoriasis and eczema. I want to drive this point home. It was a great study done by Max Fung and others when I was at UC Davis, looking at very clear cases of plaque psoriasis that responded to traditional therapies, but they looked at their biopsies. And what's really interesting is 76% of these specimens had spongiosis, 50% had dermal eosinophils, and these are patients that weren't having observed sort of this switch, this paradoxical eczematous reaction. And so the point here is that a lot of clinicians fall into the diagnostic trap of saying, well, I biopsied and it had spongiotic dermatitis with eosinophils, therefore it was eczema, and they end up putting them on treatment. So it raises this question, which is one that no one's really answered in the field yet, which is, what happens when you unintentionally treat a non-psoriasis disease with a targeted biologic? And part of what you're going to see in this group is that we don't know. What happens to lupus on an IL-23? What happens with urticaria on an IL-23 or bullous pemphigoid? Like these, we haven't really done those experiments, but it raises this important question that some of the reactions we may be seeing are actually misdiagnoses from the beginning, and we're starting to witness what happens to that immune response when we hit a targeted portion and then let other immune circuits start to go in a different direction. So this creates an important problem that has to be addressed in the field. Having these diagnostic biomarkers is going to be important to help differentiate that we thought what they had from the beginning is actually what they had initially. Otherwise, we're saying, oh, we called it psoriasis and they had this switch, when in fact they had a different disease the whole time. But there's another subset of these patients, which Andrew hinted at, which is the background of atopy and secondary infections. And I'm going to give you just kind of a snippet of some of the literature here so you can see. This is incomplete literature, but it starts to give you a little bit of insight into a theme that's going to come across. So basically, we look at different studies where they're starting to look at these groups. So here's an observational retrospective study, 54 cases of the eczematous eruptions and chronic plaque psoriasis after an IL-17 or an IL-23. Interesting, no big difference in male versus female, and the mean age of onset was 52. Now, I'm going to drive that point home a couple of times because all the patients I've seen that have ever had this reaction, all of them were older patients. And it starts to raise questions about what's happening to immune tolerance and some of the changes that happens with age. You're going to see that come out as a feature throughout some of the literature. But interestingly, 44% had atopy as a history, 30% had atopic conditions, and then 20% previously had eczema. Very interestingly, we're learning something about these patients where the vast majority of them have some history, and a lot of patients don't recall that childhood history, may have had it, so getting some of that history going back. Some of these patients find out, oh, actually for my parents, I did have these rashes that would kind of come and go, and pretty typical eczema history, they weren't aware of it. But interestingly, for the culprit, when you look at the offending medication, what was the medication that caused this switch or was related temporally with this switch? And most of it's IL-17. You can see almost half of the cases, secukinumab, ixekizumab, but brodalumab, also an IL-17 receptor blocker, and very low rates for the IL-23 medications. And interestingly, in all the patients in this analysis, they all achieved remission, this reaction, whatever the driver actually resolved. So it's telling us something about this IL-17 pathway, and you'll see both the IL-17s, but also ustekinumab come up very commonly in literature. So here's another presentation. So this is a 50-year-old female, had a history of GPP, so not just plaque psoriasis, but other forms of psoriasis. Had GPP, asthma, Sjogren's syndrome. So we've got somebody that's got multiple conditions, different pathways. And interesting, in this patient, IL-22 increased. They didn't measure IL-36. So the question here is, was this really a flare of their underlying eczema or their asthma, their atopic condition, or was it really a flare of their underlying GPP? So Andrew brought up the point of erythrodermic psoriasis. Well, erythroderma in general is very difficult to pin down a diagnosis just on a single exam, and so we start to do a workup in these patients. So in this case, the question is, could some of the manifestations here have really just been untreated or inadequately treated GPP? But what's interesting is in this patient that flared, when they looked at some of the cytokines during this flare, this paradoxical shift, there was actually no increase in the type 2 cytokines. So it raises the question, is this really eczema, or are we just calling it eczema because we're not seeing the same immune profile that we see in these patients who have traditional eczema? And that fits with what we know about things like paradoxical psoriasis. We know it's not really psoriasis, it's not really pustular disease, it's kind of in the middle. So I think that gives us some insights there. But again, this is a patient with underlying type 2 disease. Here's another 25 reactions in Verona, Italy. Reaction onset was between 3 and 24 months. Also very interesting. If this is drug-related, why isn't it happening within the first 3 to 6 months? Why would a patient have this shift after 2 years of being on therapy? So it raises the question about the temporal relationship with these therapies. Diagnosis, histologically confirmed. I already raised the concerns around that, because how do you really confirm a diagnosis when the pathologist can't consistently do that? But a strong atopy history in over 60% of patients. The JAK treatments worked really well. So again, getting back to the point of broad spectrum in terms of hitting multiple immune circuits might be helpful. And these patients well controlled with anti-IL-23. So again, another theme coming out from the literature. Another case, paradoxical eczema. This one I think is quite interesting. I've seen this a few times. 31-year-old male, plaque psoriasis since age 10, not responsive to traditional therapies. It's always interesting when these patients don't respond to cyclosporin because it raises questions about the underlying immunology. But this patient initially had clearance on an anti-IL-17A, skin cleared, and then later had this reaction, this change in the phenotype. This patient turned out to have a positive MRSA infection and treated the infection, was noted to have high IgE levels. But then, very interesting, this patient was put back on the same IL-17A inhibitor and actually had good control. I've had this happen multiple times. A patient was doing well on a psoriasis medication. Turns out they had this erythrodermic flare, a sudden shift in their phenotype. We found an underlying infection. I've seen that a few times. So these are potential confounders that happen. But the fact that the patient could go back on the same medication after the treatment was cleared and not have this reaction again is quite interesting. So there are groups that are now starting to look at this. Andrew also hinted at this. Could there be maybe some genetic overlap in the genes that might drive susceptibility for both plaque psoriasis and eczema? So this is a looking at, again, retrospective, over 3,000 case controls versus 88 case cohort controls, so 4%, right? And we're looking at GWAS. So we're trying to identify, could there be some genetic markers that might help us identify the susceptibility? And they know what Andrew brought up, which is that there's already been work done showing that there are some susceptibility loci which drive risk or risk factors for both conditions. So are we picking up some of these patients? Most of the patients that had these reactions were either anti-TNF or IL-12/23, so you already heard about that with ustekinumab, most commonly associated. But a couple of real interesting insights. Most of these patients were female. They were typically older age by mean age if you looked at their years, and almost all of them had a prior history of atopy or a diagnosis of psoriatic arthritis. So raises the question about these patients as having multiple other conditions that might be driving some of these immune circuits. But what's really interesting from this paper is that when they started looking at the genetic susceptibility loci, you could look at patients who had described this past history phenotypically of having eczematous reactions or history versus those who didn't have that prior history but had the loci. And what was interesting is that their risk for this reaction persisted even if they'd never clinically experienced what would be classic eczema. So there's clearly some driver here in this group that whether or not they've had manifestations clinically of eczema or atopy in some form, that relationship occurred to persist, which really suggesting there may be an underlying susceptibility in terms of the genetics. So looking at some of the other ways of trying to tease out this reaction, this is the Bad Bear Group, the National Registry, Psoriasis Registry in the UK, also Ireland Center, so 168. What's interesting about this paper is they had data before the reactions happened. So at T1, this is getting serum before these patients had started biologic. T2 is after they had started a biologic, got better for typical psoriasis, and then T3 was after this shift, this PE reaction. So that gives us a chance to say, well, what did it look like before? Because one of the problems with this concept of class switching is you assume that you knew what their class was before they switched. And most people don't actually determine that. So now you have a chance to say, well, what did it look like in terms of the shift? So you have 71 PE cases, 75 controls. There was one identification, so stamp B in T1, that suggested it may correlate with these PE reactions, and it's sort of a soft link between IL-1 signaling. So interestingly, because some of these paradoxical reactions, we also see the IL-1 or the IL-36 pathway come up. So there may be one biomarker, a lot more to be done in terms of teasing out mechanisms, but may give us some insight a little bit into what may be driving this. But at T2, so this is when they got better on their psoriasis biologic, but they hadn't had this reaction yet, this shift. And you look at before it, they already have these genes that are correlated with atopic conditions. So it suggests that these patients, even before they've had this eczematous reaction, have already had some of these AD-related genes or signals that can drive sort of this atopy history. And then really interestingly at T3, after they've had the reaction, you compare T2 to T3, say they got better, then they have this reaction later. What's the difference? Well, there was no significant difference. And very interestingly, these patients didn't have an increase in type 2 cytokines. So the question this raises, is this really paradoxical eczema? Because if they're shifting from psoriasis to eczema, why are they not getting upregulation of these signals that are classically associated with eczema? So this starts to give us some insight that there may be a susceptibility, but the underlying pathway, even though we're calling it an eczematous reaction, may actually not be these type 2 cytokines. So raise the question on the work that we still need to do. And to end, just some final thoughts here. So here is actually a skin of color patient, the same idea that Andrew brought up, that these can be very difficult in terms of phenotype, but we have to consider the fact that some of these reports may actually be confounded by the fact that they've been misdiagnosed from the beginning. Because why? We know that clinically we can't always rely on our eye and the clinical features. We know that patients with inverse psoriasis often get misdiagnosed with eczema, for example. So phenotype isn't totally reliable. We still need a biomarker, diagnostic biomarker, that can differentiate between some of these inflammatory conditions. Class switching, I don't like that term because it assumes that we knew their class before. And the problem is that nobody profiled these patients before the reaction because they didn't know they were going to get the reaction. So we're learning everything on the back end. So the problem with class switching is we don't know what they had before, but we need to start learning this. I think the study I showed you, the Bad Bear study, gets closest to that and saying we have some information before the reaction, but we really need some skin data. We need biomarkers in the skin before they have this reaction. It's hard to do because you can't predict these patients. But I think what's overwhelming in these cases through the literature, and this is just a snippet of the literature, but consistently most of these patients, at least half of these cases, have some form of overt atopy. So it may be that we need to be asking about these patients and some of those cases, but there are true de novo presentations. The very first case I saw was a 68-year-old male that had very classic appearance of plaque psoriasis, and he totally switched. I asked him every question related to atopy, couldn't find one single thing. Never had a rash, didn't have seasonal allergies, didn't have asthma. So we do have some de novo presentations that we do need to tease out, because I think these observations suggest that's the case. And this idea of unmasking, I like the concept unmasking because it tells you that something was already there. It just looked different to your eye. So I like this idea of unmasking or phenotype switching because I think it best captures clinically what's happening. We're getting components of one aspect of presentation better, and we're having others that either persist or others that start to worsen. So I think we need to think about the proper nomenclature for these cases. And I think the other thing that's really needed as the final point is that we really need the mechanism that's explaining these observations. So I think most of us in this room would agree that the clinical presentation observations is real. We just don't have the mechanism that explains why it's happening. So this is just the beginning of this work to start moving forward. Why the IL-17s tend to be more related rather than the IL-23s raise this question that IL-17 has this protective immunity. I think there may be this crossover with infections as these patients on IL-17s have this hampered response that are we then setting off something else in these patients, for example, in colonization, bacteria infections, for example. So I think a lot of work to be done here, and thank you.
Thank you, Jason. So Ken Gordon now comes to the lectern, and just as an introduction, Ken is a professor of dermatology at the Medical College of Wisconsin in Milwaukee. And over the past 25 years, his clinical and research interests have focused on developing novel immunotherapeutics for psoriasis. He's been part of many clinical trials, pivotal clinical trials, involving psoriasis medications. He's on over 250 publications, including first author publications in the New England Journal, Lancet, and JAMA. He has served as the Center of Clinical Research Director at Northwestern, and until recently, he was the chair of dermatology at the Medical College of Wisconsin. He's a longtime IPC counselor, and he's going to speak now to the clinical approach to these quote-unquote paradoxical eczematous reactions.
Thanks very much, Bruce. Thanks for the introduction. And, you know, when we were given this topic, Jason and I were talking about, what do? We don't know exactly what's going on. I kind of like the concept of uncovering or unmasking of lesions. We've talked a lot to people over time about immunologic switching, which I'm not sure what we can say about that in the patients who have atopic histories. But without even full knowledge of what's going on with these patients, we're all faced with them. We have to do something about them, and we try to make them better. And so the question I have that I've been tasked with today is sort of trying to think of what's the best educated technique to approach these patients. And I say an educated technique rather than a evidence-based technique because we have so little evidence to go on. And so what I'm going to go is how I think about these patients when I see them in my clinic, and try to bring in as much evidence as I possibly can, including some new observations that haven't even really been published yet, have been presented, that might direct us in some way of thinking about these patients. But first, let me just give you here my conflicts of interest, and they're multiple. So the question is, how do you approach these patients with a paradoxical reaction? And again, the term paradoxical is used very loosely in this case because we don't know that there is some paradox. It could be that you're controlling one arm of the immune system and allowing another one to show up that would have been there anyway. We don't really know. So what are the questions? One is there value in counseling patients before we start a biologic therapy for psoriasis? And I think that's a really critical question. Because I will tell you, most of these patients that show up in my office are referrals from people who were started on an agent for psoriasis and it just isn't working. And they come into my office, and I would never have guessed they had psoriasis in the first place. But they were diagnosed with psoriasis initially, and then they weren't. So the question is it important to talk to the patient, not only because it's a possible thing that might emerge, but also because that patient might be able to recognize what's going on, where the clinician might not. Secondly, if the reaction does occur, is there any kind of diagnostic evaluation that helps us in this case that we should be doing it? There are many dermatopathologists who I've worked with over the years who've hated me over times because I have the philosophy that I've taught residents, when's the right time to biopsy psoriasis? Any thoughts? Never. And the reasons for never is just as was pointed out, everyone has got spongiosis. Everyone has scratched their lesions. It will get you down a pathway that's very difficult to understand. Do I change my mind with these patients? And finally, what's the therapeutic approach? And that's really what's important in trying to figure out how do you help these patients. So first of all, what's the incidence of this? And we really don't have a good understanding. A lot of numbers are thrown out. Typically, a number that gets thrown out to me is 1%. And that's because of a great issue from Bad Beer, which is obviously a prospective psoriasis registry and is probably as good as anyone that's out there right now. And they come out with about a 1% incidence. There are other reports, however. There was another report. There was a retrospective analysis that was 2.3%. What do I think when you look at this variant? There are some estimates that go up to 4%. My argument would be, I think this is probably underestimated because so many patients are switched from drug to drug to drug on psoriasis because they are not diagnosed as having something that's different from their original psoriasis. The rates seem to be different on different classes. And again, this is from the Bad Beer Registry, that the IL-17 seem to be the most common. The anti-TNFs, where this is probably where the first place it was described, was similar, and the anti-IL-23 inhibitors specifically seem to be the lowest, though anti-IL-12, 23 were sort of in between. Now, the one thing I want to bring out that is it might be less common with anti-IL-23s, but it's not zero. It's low, but it's not zero. So you have to think in terms of all of our specific medications for psoriasis that this is a possibility. Obviously, as Jason pointed out, it's much higher in patients with a personal or family history of atopy, and that's going to be the great majority of patients that I've seen. Even if the patients on first glance will say, no, I haven't had anything, when you keep on hammering, oh yeah, I do have seasonal allergies every fall or every spring, and so you pull something out when you really start talking to these patients. So I think it is important to really take as detailed an atopic history as you possibly can for both them and their family. I had a patient, I think it was probably about a week ago, who said, oh, I've never had anything known in my family, but man, my kids have horrible allergies. Well, there you go. And so I think most of these patients, you can tease something out. I do generally, because of this data and the low incidence, don't counsel patients specifically on this reaction. I think it's too uncommon and you get people thinking about this. However, we have a entry questionnaire that we have when patients enter our clinic. And if they do have a history of atopy in any form, I do mention, by the way, if your skin seems to change around, let me know. It's something that we might want to be considering in the future. So I do bring it out in the patients who have a clear history of atopy. So evaluation of the patients. It's not universal. I think it's more universal than the data would suggest, but I think it's not completely universal. The biopsies that have been studied are consistently are spongiatic psoriasiform dermatitis with eosinophils. And those who have had IgE levels measured, as we've had a couple patients discussed earlier today, they're generally quite high. So in some ways, the biopsies, the eosinophils, and the IgE levels seem to be consistent with a very atopic condition. There's a complexity in the issue of initial diagnosis. I think that's what Jason really pointed out quite well. And when you get a biopsy after the fact, you don't know what you had initially. So my thought is when taking the diagnostic workup and whether we do a biopsy, does it actually change what we're going to do for the patient? And my argument is, except for one thing, no. And that one thing is cutaneous T-cell lymphoma. It's always the thing that's sitting in the back of my mind. RCT-CL doc, we'll talk about in every differential at grand rounds, we'll say, oh, that's CTCL like lupus, or it's lupus like CTCL, or eczema like CTCL, or psoriasis like. We actually now have normal skin like CTCL. So I think in almost every case, that's the one thing that goes through my mind that I could have missed. Now, there are a couple of hints of physiology that we haven't talked about. You know, immune deviation is something that we talked about, and it's really yet to be demonstrated. I will tell you, I spent a lot of time in my postdoc working on immune deviation in mice and different reactions to MS in things in mice. And so I believe everything's immune deviation. But I don't think it's been demonstrated in this at all. I think uncovering and unmasking is a much higher likelihood. But there are other possible immunologic pathways that might be interested. And I want to point out this poster that was presented at the ISDS in November in New York. Now, I want to say I really wasn't prepared for this. I was actually chairing the session. It was the last session of the meeting on Sunday morning, so most people had left already. And I started listening to this presentation, and I suddenly was looking for a pen, trying to write down notes on this. And so what you see in terms of the interpretation is my best recollection and the abstract. So there's a lot of data in this that I'm not going to do justice to in any sort of way. However, I think it was very fascinating. There's this TNF superfamily protein called tweak, which I think is a great name for looking at paradoxical reactions. And it can synergize with interleukin-13 to produce a Th2 type response. Anti-TNF therapy has been demonstrated to induce tweak in patients. And the inflammation associated can be a Th2 reaction with one big difference. And there seems to be a significant type 1 interferon reaction. And if you look at paradoxical reactions that we see with almost any agent, type 1 interferons tend to show up. And so I just want to point out that when we think about therapeutically, there might be something other than just treating Th1 and treating Th2. There might be something else, another third pathway that might be very relevant, and I think the type 1 interferon pathway is something we should consider. So what are the possible therapeutic approaches? Now, there's a wonderful review, again from the Bad Bear, and that's the first reference on this slide, that looks at all the patients in their registry that had this. And basically, there's no cumulative data set that's presented simply because everything that's possible has been done, and sometimes they work and sometimes it doesn't. So one of the things that happens is you can continue with biologic. Just add topicals or phototherapy, you can see if they make patients better. Some patients get better with that, some patients don't. And sometimes patients get better maintaining the original biologic. You could change the biologic. The one report that Jason pointed out, talking about going, all the patients improved with going to an anti-IL-23. It's possible. Do you change class or do you just change biologic? I would generally think about changing class, but that's not what was done with all the patients. Sometimes it was changing within the same class. You can stop the biologic and treat topically or with phototherapy. Well, what happens in those cases? Usually the primary disease will come back. So you go from having psoriasis to this paradoxical reaction back to psoriasis. And then you can change what most of us are doing, is change to an agent that has less specificity and will diminish inflammation from both Th1, 17, and Th2 immediate inflammation. I think that JAK inhibition is really my go-to right now in the patients who are particularly severe. I want to point out, you have to think about what JAK inhibitor you're using. Because if you think about using a Th2 response, hitting to IL-17, and potentially a type 1 interferon, you're going to need to hit, if you're just hitting the JAKs, JAK1 and JAK2. If there's a patient who's at high risk and has a psoriasiform phenotype at start, I would actually think about using TYK2. Because if everything with tweak required the type 1 interferon reaction, and blocking TYK2 will hit the IL-17 pathway through IL-23 and type 1 interferons, something that has absolutely no evidence, but I think makes some logical sense to think about, especially when we have the second generation of TYK2 inhibitors. Obviously, cyclosporin's been used quite a bit. We don't use a lot of cyclosporin in our practice anymore, but I think this is one of the places that we have gone to it. So here's our approach. We do have a number of these patients, And we are trying to figure out a sort of standard approach for it. But this is the world according to Ken, and Alan and Bruce have both known me for a long time. That doesn't necessarily mean the real world. We have no idea what our our clinical impression was correct, but if we have an idea about an initial improvement, that lends credence. So a lot of these patients, like some of them we've heard about, have initial responses of their primary disease, and then after that response, have a new onset of this different phenotype. I actually think that gives credence to the fact that we are treating psoriasis initially. We will biopsy to verify, but not to make sure that they have atopic dermatitis or a paradoxical eczematous reaction. I just want to make sure they don't have CTCL. I've been wrong before. 1977, I think, was the last time. Our initial plan is to continue the antipsoriatic biologic and add topicals or phototherapy, because generally the primary disease is better in these patients, and so we try to treat them. If unsuccessful, we'll change the biologic, most likely changing to an anti-IL-23, but sometimes we go to vice versa. But we really do move into JAK inhibitors quite quickly with significant JAK1 blockade. Many of the patients have psoriatic arthritis, as Jason pointed out earlier. In that case, cyclosporin is actually a pretty poor drug for psoriatic arthritis, and so for that reason, the JAK inhibitors really have primary use. So with that, in conclusion, paradoxical eczematous reactions are at low rates, but I actually believe they occur. I don't know if they're paradoxical. They might be unmasking, they might be some other phenotype of a primary disease, but the change in phenotype clearly does happen. We have a hint that most of these patients have some atopic propensity, but not all. The pathophysiology, understanding biomarkers, understanding what's going on immunologically will give us the best pathway to look at how to treat these patients. But the best signal I have right now is both the type 1 interferon and a Th2 pathway in these patients, so expanding the pathway to also include psoriasis treatment is important. And we don't have a treatment algorithm. It's not there, and it's not going to be there for a while. But I think it's something that we're going to take a lot of centers and a lot of people, and hopefully this talk will set up a number of things to make people think of hypotheses that can be tested to take better care of these patients over time. And with that, I say thank you very much.
Okay, so we'll take some questions if anyone has any. You want to go to the microphone? Joel, you're going to be the inaugural questioner.
Fast today. Is it on? Yeah. First of all, it's a great session, a really necessary one. I have two sort of questions. One is there's sort of eczematous reactions that we see with biologic psoriasis, and then there's eczematous reactions, like severe stuff. So for this 23s, when I see the eczema shift, it's usually fairly mild, sometimes a little extensive, but not like exuberant the way you get with 17. I'm just curious if that's other people's experience or is this unique from what I'm seeing?
I would say it's probably my experience, though I have to say I've seen it in all cases. And so I've seen some quite significant reactions with IL-23s as well. I do see this more frequently than I thought I should, but I think a lot of it's referral patients, since we see most of the referrals for the state of Wisconsin. And so I think in a general sense, yes, but it doesn't preclude the fact that you have severe patients with anti-IL-23s as well.
And then I'm curious about what you guys do when they have severe sort of seborrheic eczema presentation, really inflamed scalp lesions that are weeping and often colonized with staph. Let's say they were on a 17, like, would you put them on a 23, or like, how do you balance that situation? Because you want that to settle down. It's really hard to treat in the acute setting.
So, Joe, I think, you're bringing up a good point, which I think raises the question about why IL-17s might be a little bit more observed with this than, say, the IL-23 class. So, again, going back with IL-17 is creating that innate protection. Like, that's the one drawback to that class. I've had one patient that had this exact presentation, it's really severe, actually did quite well on the 23. So, I think it raises the question that are we allowing some background innate protection? We know that IL-23, for example, doesn't regulate innate cells that can make IL-17 cytokines. So I think that idea of candidiasis that we don't see with IL-23 blockade, it raises the question of some of these patients, and that's why I brought up that case on infections, that some of these patients get secondary infections. And in the presence of these secondary infections, if they have this background of atopy, it can flare. And I've seen that now in 3 patients where in each case we've either found a viral infection, a bacterial infection, or MRSA. And so I have personally had success, a very small number. I don't think a lot of people have a ton of these cases, but switching to IL-23 actually worked pretty well.
Okay, thanks.
Hi, thank you for your presentations. They were really good. Actually, I want to ask, I totally agree with what you said, that it's a problem related to the target therapies. So I'm from Brazil, and in Brazil, we didn't have quite the opportunity to use TYK2 inhibitors. It was hard to get founded, and then we got some free samples, and now we don't have that anymore. So we have just a few patients. So I want to ask you, the ones who had opportunity to use TYK2 inhibitors, which is a little bit broader than the biologics, was that a problem too with TYK2, or was not that common to see eczema induced by TYK2 inhibitors?
I didn't see anything, I didn't find any cases of this being described with deucravacitinib, so it's an interesting question. Ken's point about a possible mechanism with type 1 interferons is interesting, but throw a little wrench in that idea is that remember that one of the second most common medication along with TNFs is IL-12 and 23 inhibitors. And remember, TYK2 blocks both type 1 interferons and IL-12 and 23 signaling. So the problem, it's possible we could see that. But the other biggest problem, I think, in these patients is that TYK2 therapies are they're pretty weak overall in terms of psoriasis clearance. And these patients that have these more severe reactions, like we're seeing optimal peak response with deucravacitinib at 24 weeks. Right? So it's a problem with these patients not being very fast acting. So it creates a practical problem that way, even though it may actually hit a cytokine that's at least contributing in part to the physiology. But I didn't see any reports where that was the primary agent that led to this shift.
Just to add to that, we haven't either, but we have used it occasionally where you've had a patient on an IL-17 who has developed this to see if you can settle the eczema and also keep the psoriasis calm, and it hasn't on the whole been overly effective, I'm afraid.
Yeah, I actually think it's something that's very fascinating. I was one, who theorized it might be a benefit. Not sure about that, by the way. But I think it wouldn't show up with deucravacitinib. It could show up with the second generation TYK2 inhibitors because their potency is quite significantly higher in terms of their impact on gene expression. So I think that's a question that's still waiting for an answer.
Yeah.
And they work a lot faster, to your point. I think that the second-gen TYK2 inhibitors, we're seeing a really dramatic shift in terms of the time to clearance. So it's a really important point that may actually play more of a therapeutic role in the future.
Yeah, I think it happens, as also answered Joe Gelfin, it happens with, I have patients that started with IL-17, then we change for 23. It keeps going, the eczema, so you add cyclosporine, we take everything off, use JAK inhibitor, you control the eczema, but the psoriasis comes, and so I thought maybe TYK2 would be an answer for
Yeah, I think it's worth a try. To be honest with you, if you're trying take upadacitinib, which is primarily JAK1, but also impacts JAK2, you would block everything that you block with TYK2, with those two. You still don't always get great responses. So it's hard to say. And again, I don't want to call it data, but the case series that have all the different things that we're trying, it's all over the place. There's really no place we can make an algorithm for how to treat these patients.
Thank you very much.
Luis.
Thank you. I've enjoyed all the presentations that have a terminological issue. Please stop talking and writing about paradoxical eczema. This might be flummoxing eczema, but never paradoxic. If you have one patient with asthma that you treat with dupilumab and the patient develops eczema, that's paradoxic eczema because dupilumab improves eczema. If you're treating one patient with an interleukin 17 inhibitor and the patient gets super infected, or perhaps you shift the polarization of the T response towards Th2 or interferon or whatever, that's not paradoxical eczema. That's a shift or switch or whatever you want to know it, to call it. But please correct this because it's not good English.
Great. I love it.
And
think,
not English anyway.
No, I totally agree. I think there is work to be done on the language around this. It might sound superficially like semantics, but it really matters because it drives how people think about these conditions, and
Words
we
matter.
need a different language to describe these reactions.
Spanish, maybe? Catalan, yeah.
Thank you.
Couple more questions, yeah.
Hello, I'm Dr. Barbet Ferreira from Brazil. I have two questions. First, I have patients with also two diseases, also atopic dermatitis and psoriasis. And we have some problems with access in Brazil. It's very difficult for us to use JAK inhibitors. And it's easier for us to use dupilumab. Especially in older patients, it's also safety for us to use dupilumab. So I'm asking you, not only about the access, but also about the safety in older patients. Why don't you talk about this in your session? For me, I'm a JAK lover. I have a great experience in JAK inhibitors, but in this kind of patients that have both conditions, atopic dermatitis and also psoriatic, why don't use together a dupi and also a biologic? Can you talk about this?
Sure. So I've had a number of patients who were treated for psoriasis, got a phenotypic alteration. Is that good, Louis? And then were changed to dupilumab, and then got a massive psoriasis flare. Now, the question of using both, we would love to use both, at least in the United States, in my experience, and I don't know about in the UK. But we are oftentimes inhibited by our ability to obtain both from payers. And in fact, most payers specifically say you cannot use both. So in our case, we need to go on broader, sort of single agents that have broader treatment rather than using multiple agents. But I agree 100% with you. There are going to be patients who could improve, get the primary, phenotypic presentation better, and because they have improved with the primary treatment, and then use something to treat the second treatment, be an ideal, I think, in many cases, but we just don't have access to that.
Just to add on the funding side, I suppose it depends how you frame it, because if you're saying they have two different diseases, you may be able to access highly targeted therapies for the individual diseases. How you use them and whether you use them both at the same time at the same dose, or whether you flip-flop depending on what the prominent phenotype is all about the individual in front of you, isn't it?
And Andrew, I think to your point as well, remember in the label, you actually have the description with dupilumab as being associated with plaque psoriasis and also psoriatic flares. One of the risk factors is PSA, at least it's been shown in the superficial literature that may be a risk factor. So you run the risk of a patient with plaque psoriasis and psoriatic arthritis. And I've seen this happen in patients who are misdiagnosed, which is why I brought up this point at the beginning. Patients who are misdiagnosed, put on dupilumab that clearly had features of PSA and plaque psoriasis, things like dactylitis, enthesitis, and on dupilumab, they had dramatic worsening of their joints. And so I think the practical approach of when you, as Andrew brought up, when you initiate therapy, because the whole idea of treating one and letting the counter-regulatory mechanisms not hold back the other pathways creates that problem. So we'd have to think of a strategy of, you might need to initiate them both at the same time, for example.
Okay.
So I think we're going to have to cut off here. I'm sorry we can't can't have all your questions because we have to move forward with the program. But thank you very much.
Thank you.
All right, so now we're gonna bring Amy Paller to the podium. Amy should be recognized as one of the co-organizers of this entire agenda, and she's going to take over and moderate the topic of psoriasiform reactions in patients receiving treatments for atopic dermatitis and prurigo nodularis.
Thanks so much, Bruce. We'll move forward now, and unfortunately, Sean Quatra, who was supposed to be here, has had some travel issues, so he has kindly recorded his talk. I'm afraid we're going to have 2 talks in this session that are recorded because of travel issues, but we'll move forward, and do allow me to at least present him in absentia, and then we'll go ahead and hear from him about some clinical presentation. So Dr. Sean Quatra is the Joseph W. Burnett Endowed Professor and Chair of Dermatology at the University of Maryland School of Medicine in Baltimore, Maryland. That's in the United States, of course. His area of clinical expertise includes chronic pruritus, prurigo nodularis, atopic dermatitis, and dermatology for ethnic skin. He's funded by the National Institutes of Health and multiple foundations. He runs a basic and translational research laboratory along with the clinical trials unit. He's been an author or co-author of more than 250 publications. Dr. Quatra is an IEC counselor, a member of the National Eczema Association Scientific and Medical Advisory Council, and past Secretary-Treasurer of the Skin of Color Society. So with that, can we now show Dr. Quatra's presentation?
Hello, everyone. I'm Sean Quatra. Sorry I couldn't be there in person today, but I'm excited about being able to share this presentation with you all today about clinical manifestations of psoriasiform reactions in patients receiving treatments for both atopic dermatitis and prurigo nodularis. These are my disclosures. So to start, a lot of us are seeing these adverse reactions, psoriasiform reactions in patients treated with both AD, who have AD and PN. Dupilumab is the biologic that has been approved the longest, so we have more data on that, but we're also finding more data on tralokinumab, lebrikizumab, even some data on JAK inhibitors. It's important that we can harmonize more about this phenomenon. We'll start by jumping into atopic dermatitis. So these psoriasiform reactions have been reported about 1.8 to 3.3% of adults on dupilumab, similar number for tralokinumab, although there's less data. And we know that this may be representing a phenomena associated with precision medicine and targeted biologic monoclonal antibody targeted therapy, because when you look at these psoriasiform reactions with drugs like dupilumab versus standard immunosuppressants such as corticosteroids, methotrexate, cyclosporin, or azathioprine, we know that biologic use is associated with an increased risk for developing psoriasis, one study around 58% increased risk for dupilumab. Well, what kind of reactions do these patients have? And we're going to get into a number of cases. But first off, the literature so far from the smaller studies and aggregation reports suggests about 77% of patients develop plaque-type psoriasis. And then you can see smaller numbers of patients with erythrodermic or whole body psoriasis, more smaller lesions consistent with guttate, pustular, inverse, or SIBO psoriasis. And in addition to most of these lesions falling into plaque psoriasis, most of these lesions are also in typical psoriasis distributions, extremities, the trunk. There's no gender disturbances or differences as well, which is reassuring. In terms of duration and appearance of the psoriasiform reaction, studies have suggested usually it's on the order of magnitude of weeks. One study showed about 20 weeks average duration in adults and 32 weeks in children, but it's been reported in the literature to range from as little as 1 week of biologic exposure up to a few years, 2.5 years, even longer than that. So you can have quite a variance in that development of these manifestations. So let's jump into a patient case. This is a 92-year-old male, atopic dermatitis, who also had atopic dermatitis since childhood and classical eczematis, pruritic plaques with eroded vesicles along the mid-arms and cubital fossa, just classical area, been managed with phototherapy and topical steroids. So a great candidate for biologic therapy, dupilumab, as we all know. Patients dupilumab helped the patient's atopic dermatitis get much better. However, once those atopic dermatitis plaques resolved several years later, you can also see a development of these scaly pink plaques appearing on the thigh, consistent with a psoriasiform reaction. So if you look closer at this patient, there are biopsies both before and after therapy. You can see before therapy, you have pretty classical morphology histopathologically for eczema, especially that apparent spongiosis that you have. And after dupilumab therapy, what's notable here is the significant acanthosis, parakeratosis with abundant neutrophils and the loss of the granular cell layer, all suggestive of psoriasis. So you have the clinical manifestations of psoriasis, the histopathologic appearance also consistent, and then you also have molecular confirmation on a cytokine expressional shift. So if you look before dupilumab therapy, you can see this staining of IL-13 that dissipates on dupilumab therapy, which you'd expect, or therapy with tralokinumab or lebrikizumab. And then IL-17A levels, which were not high at baseline, actually significantly increased. You can see by this staining here. So you can also see on these diagrams how that IL-17A shifts. And this starts the conversation of, well, we have an impressive precision medicine revolution with many of these monoclonal antibodies. But when you target one of these cytokine targets, then you can oftentimes have this shift in this balance that's present. So we'll get into that a little bit more. This patient in particular started on mycophenolate and then cleared both AD and psoriasis. But again, we don't like being on these non-specific immune suppressants. When you look overall at adverse events, cutaneous psoriasiform reactions with dupilumab, this is from the FDA's adverse event reporting system. You can see most of these cases were classical psoriasis, as was shown earlier, less of the pustular, guttate, erythrodermic, nail, paradoxical psoriasis, any of those things. And this is the immune shift that we're getting at. So, once you have that dampening, in particular of that IL-13 levels, almost this seesaw balance-like interaction where you have this sudden upregulation of some of these psoriasiform molecular genes, IL-17 in particular. And what's also supportive of that phenomenon is that dupilumab responders, through all the cases that have been reported, seem to be more likely to have these psoriasiform reactions compared to non-responders. You don't see many reports of dupilumab non-responders having these psoriasiform reactions, probably because those IL-13 levels haven't successfully been decreased, or there's broader immune axis involvement. So I have to highlight an incredible article by Dr. Thomas Bieber's group looking at some risk factors that may predict who develops this flip-flopping between atopic dermatitis and psoriasiform phenotype. So you can see here in this study, what was done was these patients were looked at who developed these psoriasiform reactions and used some machine learning to be able to come up with what are some of these shared features. And you can see here that patients who are more likely to have a different phenotype upon treatment with biologic therapy oftentimes do have some medical history in the family of psoriasis or joint pain, dactylitis, and then patients who may shift over to eczema conversely may also have some personal history of atopy. So patients most likely to flip-flop do have some of these shared features of both. So let's move on. What about the joints? Also, that's a big question. Is the skin limited? Is it joints? Well, our second case is a patient who's had atopic dermatitis since childhood and been on dupilumab for a number of years, developed these psoriatic lesions, thick scaly papules, coalescing into plaques, but also complaining of nail changes and widespread joint pain. So you can see the rheumatologic workup and many of these indices were within normal limits, but the bone imaging, you can see that there's increased uptake in the sacroiliac joints, sternoclavicular, ankles. This patient was diagnosed with psoriatic arthritis. Switched off dupilumab onto a broader acting immune agent targeting more of the cytokines associated with both processes, upadacitinib 30 milligrams, and the patient cleared. And you can see this process of starting dupilumab, the onset of psoriatic lesions, and then the rapid resolution with upadacitinib therapy. So we know that the psoriasis is slightly more common than dupilumab versus controls, looking at multi-center data. Again, very low N, but did reach significant looking at global multi-center data. Psoriatic arthritis, the reports are very low, so you can see about 13 in this study, excellent study highlighted here, which didn't meet significance, but we know that there are these cases of it isolated and happening. Let's move on to another biologics. This is a patient with eczema who developed who was started on tralokinumab. And you can see, again, this patient developed psoriasiform-type lesions, In addition, scalp psoriasis, this patient had pretty significant on the frontal hairline, and you can see very classical biopsy here for psoriasis, those subcorneal Monroe's microabscesses and all that hyper and parakeratosis, acanthosis as well. So next case, patient who had itching 10 out of 10, itch dominant perhaps. And we know that nemolizumab is actually an agent that is associated with eczematous reactions. But what's very interesting here is probably some overlap features in this case. I thought this would be interesting to highlight for you because we're traditionally thinking of IL-4 and 13 therapies inducing psoriasis, and that nemolizumab may shift over to eczematous reactions in small subsets. This patient also developed some of these plaques consistent with more of a psoriasiform process. You could argue this is more of an overlap, but this did improve with the treatment. And you can see this process here, and this patient got better with upadacitinib as well. So let's now shift gears and look at psoriasiform reactions also in prurigo nodularis. So in prurigo nodularis, of course, from nemolizumab, we know there's some eczematous reactions, and from the pivotal phase 3 trials, but from dupilumab in the real world, we're also seeing some psoriasiform type reactions. And the biology of prurigo nodularis is interesting because there's certainly type 2 upregulation in the skin. This is some gene set analysis work, but in the blood, there's marked IL-13 levels that increase, but it's also a little bit broader. There's IL-22 involvement. You can see other immune axes that are involved here. And actually using a precision medicine approach for prurigo, you see that patients actually have variable degrees of type 2 and type 17 involvement across these axes. And so some of the slower responders to an agent like dupilumab may actually have induction of more of this type 17 capacity, which we'll get to. So let's look at a case. This is a 68-year-old female, pruritic nodules in the buttocks. I've been checking IgE in everybody because to me that's now becoming one of our tightest, like TARC, but readily clinically available biomarkers of type 2 inflammation. So this patient had very elevated IgE, started dupilumab therapy, and look at that immune switch phenomenon. In my mind, this elevated IgE says this prurigo patient was a very type 2 dominant patient. And so potentially shutting down that IL-13 may have predisposed to more of this shift to this classical psoriasiform phenotype. And you can see that switch happening here, especially that exocytosis of the neutrophils, forming these large subcorneal spongiform pustules. So this patient did discontinue therapy, and the follow-up had resolution of the psoriasiform lesions, so a little bit more evidence also of this process being attributable to the causative agent. Let's look at another patient here. This is a 42-year-old male with some of these itchy nodules, Caucasian male. You can see classically on these extremities, started on dupilumab. And it's a little bit faint here, but there's improvement. Again, like many of our cases, I'm not aware of many cases or any cases of patients who are not responding and then having immune switch phenomena. So it kind of highlights the importance of target engagement. So this patient actually had great resolution. Look at these nodules that are almost completely and totally faded. So that's pretty significant there. But they had the development of more linear, scaly plaques. It's a little bit harder to see in this photo, but when you zoom in, you can totally appreciate these whitish scales. And then on the biopsy, the parakeratosis, acanthosis, more dilated blood vessels, papillary dermis, perivascular infiltration there, these lymphocytes as well. So more of a psoriasiform switch. And I've had actually personally multiple patients with such a switch who were super responders. So this patient in particular had their dosing adjusted and did well with topicals because these are very amenable. I've actually also used several other non-steroidal topicals that have helped a lot in some of these more mild cases. But the good thing is these patients usually have their prurigo much better. And then in my experience, this hasn't been a huge deal, especially most of the time since it appears in prurigo to be more of a milder phenotype. And you can see just how this happened. So the patient was started on dupilumab. The psoriasis eruption started after a few months and then resolved at about 2.5 months with no episodes of recurrence. So I'm going to share another case with you all. This is a long-standing patient of mine who has very significant prurigo, totally diminishing her quality of life, and initiated therapy with dupilumab. She had a gradual improvement, which I'll get to. But she came back after she was having a treatment response to dupilumab with the development of new pruritus of the scalp. And I looked, and you can see here very clearly these psoriasiform lesions, scalp psoriasis, that this patient had that were very itchy. So this is where her itch shifted to, from the lesions to here. We continued dupilumab, and actually, in addition, the patient decided to start apremilast and had a pretty good response quickly there. What I wanted to highlight with this case was that the dupilumab study for prurigo was only 6 months, but in the real world, we know that the degree of type 2 inflammation is variable. This patient probably had more mixed type 2, type 22, type 17. So they took longer to respond. Actually, the itch took quite a while. And even over 12 months, even though lesions were slightly improving. But when she started having such a great response, which tells me that type 2 activity was being knocked down, that's when this scalp psoriasis seemed to emerge, probably when you had a total target blockade as well. So that's kind of the emerging theme from a number of these cases in my own personal experience from treatment. So I'll take away a few things. So psoriasiform reactions, which I'm so glad we're focusing on this joint forum, may emerge in both AD and PN. Timeline about 20 weeks in adults with dupilumab, 32 weeks children, and reflects pathogenesis immune drift from type 2 to type 1 and 17 inflammation. Patients with a personal or family history of psoriasis may be at a greater risk. And again, we have such an amazing amount of targeted systemic and topical therapies that oftentimes we can successfully manage these patients and keep them on therapy or shift to other therapies. So thank you all so much for your attention.
All right, well, thank you, Sean. He's not really here, so I don't think he can hear me. We're going to move on to our next pre-recorded one, and this is from Dr. Yael Lashem. Now, those of you who know her know that she lives in Israel, and we all know what's going on there. I don't even think the airport is open, so she certainly wasn't able to join us. But let me tell you a little bit about her, and she's going to move on to tell us a little bit about clinical approach. Now, Dr. Lashem is a dermatologist and clinician scientist who specializes in chronic inflammatory skin diseases. She is the director of the Atopic Dermatitis Clinic at the Division of Dermatology at the Rabin Medical Center and is a clinical associate professor of dermatology at Tel Aviv University. She's dedicated to high-quality patient care, innovative treatments, and advancing education and research in dermatology. Her research focuses on the epidemiology and outcome measurement of atopic dermatitis. She's a member of the board of directors of the IEC and serves as chair of the IEC's Education Committee. She's also on the executive committee of the Harmonizing Outcome Measures for Eczema Home initiative, both global organizations dedicated to improving research quality and patient care in atopic dermatitis. I'm going to just get up and ready. Okay, it's my pleasure now to introduce our next remote speaker, Dr. Lashem. Oh, I did that already. I'm sorry.
You did.
I did that. I'm not going to do it again. Would you just press the button and get us started?
Hi, everybody. I truly wish I could be there today with all of you. Unfortunately, I couldn't travel because of the current situation here, but I'm really happy I can still share this talk with you and during what I'm sure is a wonderful session. I'll be discussing the clinical approach to psoriasiform reactions in patients receiving treatments for atopic dermatitis and prurigo nodularis. These are my disclosures, and let's begin. So this is really the patients we'll be discussing in this talk. These are patients from my clinic. I'm sure you all share similar patients. They all had very classic atopic dermatitis. They were treated with dupilumab in this case and developed psoriasis. And the question we're asking ourselves today is, what now? What's our next step? How do we manage these patients? So when we're thinking about treatments, we really have to start with pathogenesis. And the main pathophysiologic event underlying these psoriasiform reactions, as we know today, is that relative imbalance between Th17 and Th2 inflammation, skewing towards Th17, which gives us psoriasis or psoriasiform reactions. And classically, that's initiated by Th2 blockade, and that does make mechanistic sense because IL-4, very prominent Th2 cytokine, does have regulatory functions on the Th17 axis. So there are data to show that IL-4 suppresses differentiation of naive T cells into Th17, and it also suppresses IL-23, which is a very important cytokine in maintaining the Th17 response. If we block IL-4, we kind of take that suppression foot off the brake, and we really enable differentiation and expansion into Th17. And when you look at skin samples from these reactions, that tracks because we see a strong Th17 signature. So mechanisms are really important, and they're important when we consider treatment approaches, but they're really not the end all of our decision making. We all know that we have many considerations that factor into the way we make decisions, so it's not going to be just about Th2 or Th17. What I've done here is broadly categorize the treatment approaches, both that I've seen in the literature, in my clinical experience, and also integrating the mechanism we've discussed into four broad groups. One would be a conservative approach. We could think about broader immunomodulation towards both possibly Th2 and Th17 in a way. We could modify the culprit, possibly the Th2 blocker, or we could target the Th17 pathway, which is responsible for the psoriasis. But whatever approach we do take, I want to highlight that there is really no clear treatment algorithm, and I think this will be very easily reflected in this talk. It's all about just case reports and experiences and the mechanism. And what this means is that we really have to individualize our treatment on a case-by-case basis. This is always true in medicine, but I think these psoriasiform reactions really illustrate that strongly. So this is not a one-size-fits-all scenario. And I hope the next case, the first case I show you, really will demonstrate this. So this was one of the first patients I actually treated with dupilumab. This is a 39-year-old man, and he's a very kind of prototypic atopic dermatitis patient, very characteristic patient. He has had AD since late childhood. He also has asthma and allergies, IG in the thousands, and his family is atopic. He does suffer from metabolic syndrome. He has obesity, type 2 diabetes, and hyperlipidemia. And he, thankfully, was one of the dupilumab super responders. He cleared 0 itch, almost 0 eczema, and he was just super, super happy. But then about 6 to 7 months into treatment, he comes in with this. And he tells me how happy he is with dupilumab. He's super pleased. And he says, well, but now I have psoriasis. I was a bit surprised because he made a very good diagnosis. And then turns out that this patient, as a young child, had a few years of very classic chronic plaque psoriasis. We actually found the documentation for that, which went away, and then he started on his eczema route. And this predisposition to psoriasis possibly is something I'm going to touch on later as well. And I really like these pictures from a clinician point of view. You can see the psoriasis here, asymptomatic, very localized, and then kind of eczema remnants here. Again, psoriasis. And then I hope you can see this well. It's his ichthyosis vulgaris was kind of cavernorized all over. So clearly this patient now has two conditions. Now, this is a patient we could be thinking about, Th17, maybe a JAK inhibitor, but the patient had very limited psoriasis and he really could not care less. He couldn't be even bothered to put a topical on it. So this is definitely a patient to consider going with a conservative approach. Especially considering his metabolic syndrome background, maybe a JAK inhibitor isn't the best choice. So you can always treat through. You can treat through with the drug you're on. The psoriasis will not necessarily go away. It didn't in this patient, but sometimes that's a good strategy if the patient is happy. You can add topicals, whatever makes sense. We have topical corticosteroids, calcium urine inhibitors, calcipotriol. We have great topicals today that target both psoriasis and atopic dermatitis. That could be a good way to go. And then phototherapy is a good adjunct. So still remember, the conservative approach may be appropriate for some patients. Or we could go the other way around, kind of the polar opposite, especially if we have significant psoriasis and or still significant eczema. So we can either replace a broad immunomodulator drug. There's been a lot of reports on methotrexate when we think about conventional drugs, as well as Celsep and cyclosporin. Very variable response rates from no response to partial to complete improvement. And then kind of newer reports talk about JAK inhibitors, which do make mechanistic sense in this scenario. We also know that if you have really classic psoriasis develop in this patient, as in these patients, like the one I showed you before, there is some logic to giving a JAK1 inhibitor. JAK1s are not approved for psoriasis, they're not chronic plaque psoriasis drugs, but you can see kind of in a roundabout way from psoriatic arthritis trials that they do have an effect that's better than placebo on psoriasis. I would not prescribe them for a patient with psoriasis as a first-line drug or second, at all, but they do make sense here, and there have been reports of them being successful in this scenario in treating both the psoriasis and the eczema. This is one of my patients, not a great picture. It's hard to take a picture of scalp psoriasis, but it was very clear, and he developed psoriasis all over, cleared very nicely, both psoriasis and eczema with upadacitinib. However, there's always a but, unfortunately. There are starting to be some reports of paradoxical psoriasis after JAK1 inhibitors, both upadacitinib and abrocitinib. So this may not be the solution for all patients. Another way to go would be, well, this is a Th2 problem. Let's take the Th2 out of the equation, either by increasing the interval between injections or discontinuing the drug altogether. Now, I do want to make some points about this drug discontinuation as the only intervention, right, without providing something else instead. First off, if you have a patient with moderate to severe eczema and you're stopping dupilumab, chances are you are going to have an eczema problem down the road. So you do have to think of something else to give in that scenario. Another consideration about stopping dupilumab is that a lot of times dupilumab treats other type 2 comorbidities, and we're not, unfortunately, always even aware of that. And the one I would be most concerned about is asthma. So oftentimes patients' asthma get so much better that they stop medicating, right? They stop their inhalers, their preventive medicine, because they don't need them anymore. If we stop the dupilumab, for example, for psoriasis, we have to be really aware that these patients could get worse, could even get an asthma attack. So just something to consider when stopping this drug. Another way to go was maybe if this is an IL-4 problem, maybe we can switch to, for example, anti-IL-13 targeted drugs. And there definitely have been reports of improvement of arthralgia associated with dupilumab or even inflammatory arthritis with switching to these medications. So interesting way to go. However, again, that annoying but, we are getting more and more reports of psoriasis induced by Th13 blockers. Just recently, there was a very nice series, a cohort I think that came out that showed a 2% incidence of psoriasis on tralokinumab. So again, this may not be the way to go. This is one of my patients on dupilumab, scalp psoriasis, psoriasis in areas that were not involved in eczema. And then on lebrikizumab, there is an improvement. You can definitely see some improvement, but it did not clear, and it has not cleared since. So that's, again, a very moderate response, I would say, at best here. So the final approach could be to target the Th17 pathway, right? That's what's going on in the patient's skin right now, and we have great drugs that do that. However, this really is kind of a very strong scenario where we be concerned about a phenotype switch to exacerbation of eczema. Okay, we all know that if we treat psoriasis with either TNF blockers, but anti-IL-17 and anti-IL-23 drugs, like this patient is one of my colleague Professor Pavlovsky's patients, you can see the switch towards eczema, very classic eczema. The problem is that this is even more prominent in patients who have a background of atopy. And this is exactly the patient population we're dealing with. These patients actually have atopic dermatitis at baseline. So they really are prone to this worsening of eczema on these drugs. And I think this case, a recent case, really beautifully shows this really convoluted path that both the patients and the doctors go through in these scenarios. So this is a patient with nummular eczema type AD on the top panels you can see. And he got psoriasis after dupilumab. So the treating physician stopped the dupilumab, gave him cyclosporin, didn't take it, the eczema got worse. They added the dupilumab, the psoriasis got worse. Switched to methotrexate, didn't work. Tried upadacitinib, the psoriasis got worse. Went back to methotrexate, again didn't work. Then they tried tralokinumab, right? Psoriasis got worse. Methotrexate again, and then risankizumab, an anti-IL-23 drug, very good drug, but I would say in a way, as expected, the eczema got worse. And what they ended up doing was actually provide dual blockade with both dupilumab and risankizumab. And we do have a few patients with this treatment, and it works well. It's not the most comfortable treatment to prescribe, I would say, but it is an option. So oftentimes with these patients, you do get a sense like you're in an arcade playing whack-a-mole. So you're kind of whacking the TH2, and then the TH17 pops up. So you whack that, and you get the TH2 back up. And it's a really, that's what happens when you tinker with the immune system. That's kind of the feeling we get. And it would be really nice if we could actually anticipate these reactions in advance and prevent them, or at least make more informed treatment decisions. And this is what this work by Thomas Bieber's group from a few years ago is about. They try to develop what they call the flip-flop algorithm. And that would be an algorithm based on clinical data that would predict which psoriasis patients are going to develop atopic dermatitis and which AD patients are prone to develop psoriasis. And I think what's interesting here is the criteria this algorithm is based on. We don't have the algorithm, it's a trade secret, but they do have the criteria. Are very, there are things we do in our day-to-day clinic. It's about a medical history for both atopic dermatitis and psoriasis. And then the examination also includes very classic signs of both diseases. And I think this is something we often find ourselves doing. We really have to make sure we do in clinic when we get one of these patients and you're not really sure, is this eczema, is this psoriasis, which way is this patient going to go with my treatment? What was especially interesting to me was this family history of psoriasis, which my observation in clinic was that this was very common in patients who develop psoriasis, but I wasn't really sure if this is just, a kind of self-fulfilling prophecy, or if this really is true. So we set out to examine this in our patients. And this is a work done by Dr. Amit Eaton-Schwartz, one of our great residents. And we really looked at patients who got dupilumab and classified them based on whether they did or did not have a first-degree relative of psoriasis, so a strong genetic background of psoriasis. I will say we really try to take very classic eczema patients, so we will be very sure that what they developed was a different eruption, that's a different condition. So we excluded patients with these psoriasiform baseline eruptions, unclear psoriasis versus AD type of patients. Very classic eczema. You can see here that the patients were very similar regarding their characteristics, their baseline characteristics. Interestingly, they were also very similar in how atopic they were, even though some of them also had a strong genetic background of psoriasis. They had very similar personal family histories of atopy. Patients with psoriasis had stronger background of IBD, which does make sense, but look at the result. This is just the primary outcome. Patients who had a first-degree relative with psoriasis, 35% of them developed psoriasis on dupilumab versus 2.8% in patients who were unexposed. And that translates to a relative risk of 12.4, so 12 times the risk if you have that strong family history. So I think this is really compelling evidence to think about when we're making treatment decisions with patients. It can inform both our treatment choice and also thinking about side effect profile, adverse events, which we can communicate to the patients beforehand. So to summarize, when we're managing these patients with psoriasiform reactions in atopic dermatitis, we have to realize, we have to look at the mechanism, but look at the patient. One size does not fit all here. We have several different treatment approaches we've discussed today, and I do urge you to consider a family history, especially of psoriasis, but also just a composite history of Th1, Th17 conditions as possible predisposing factors. So I want to thank you all for your attention, and I hope you have a lovely meeting. Thank you.
All right, well, thanks to Yael. And I think we'll keep going to our live speaker for this session. Thank you so much, Killian. So I want to welcome Dr. Killian Eyrich, who is the professor and chair of dermatology and venereology at the University of Freiburg in Germany. He's also a guest professor at the Karolinska Institute in Stockholm, Sweden. I think we all know Dr. Eyrich's huge body of contributions to our field. His scientific interest is in the heterogeneity and immunity of inflammatory skin diseases, and he's published in excellent journals, Science, Nature, Science Translational Medicine, New England Journal, and the list goes on. He's also received numerous awards for his achievements, including 2 European Research Council grants. He's also a counselor of both the IEC and the IPC, and we're so glad you're here in person to tell us about what is psoriasiform spongiotic dermatitis, navigating uncertainty using advanced diagnostics.
Yeah, thank you so much, dear friends and colleagues. Actually, I like the title, Alan, and I thought this would really be nice to listen to a talk with this kind of title before I found out that you wanted to give this to me. But let's see, I really enjoy what we've heard, right? And let me take the perspective of molecular diagnostics and stratified medicine, which is, I think, a really, really well-established concept in inflammatory skin diseases, and we get more and more evidence. So just zoom out one moment of type 2 versus type 3 diseases and follow with me this I think, really nice concept, which in the core has a different signature, and this signature is usually in chronic inflammatory skin diseases related to the interaction of adaptive immunity. Most chronic inflammatory diseases are most likely at least autoimmune diseases. And then we have the monogenetic diseases, which are more rare and driven, at least many of them, by autoinflammation, right? So when it comes to T cells, we don't have that many different patterns. We have this type 1 pattern coming from cytotoxic T cells, and we do know that lead cytokines here are interferon gamma and TNF alpha, but we would not measure them. If we really want to identify them either in skin or circulation at a patient's level, we would not measure interferon gamma because it's too lowly expressed. We can almost not detect it. What we would rather measure is response genes in tissue. And this in type 1 diseases is quite clearly chemokines that are released by one transcript of interferon gamma 1,000 times in keratinocytes like CXCL9, 10, or 11. And then we do know if we have a very strong signature of type 1 diseases, which may be lichen planus, cutaneous lupus, graft versus host disease, different kind of drug eruptions, then we still land at JAK inhibitors being the best or most promising outcome. Type 2 diseases we all know, right? Obviously, these are the cytokines that are the drivers of the disease pattern, but we would rather measure again cytokines here, and we have a number of different specific biologics, same for psoriasis, which is why this, let's say, opposing diseases attract so much attention also today. Then here it gets a little less, right? These are regulatory T-cell associated diseases, and we have much less here. Everyone talks about fibrosis these days, which is rather mediated by TGF-beta. We also know how to measure it in tissue, but then what do we use as a kind of treatment? That is not really there. There's lots to do still, I would say. And the autoinflammatory diseases we know as well. So this is, I think, a promising and very nice concept. The truth is, it's challenged every day by our patients and in real life, right? So it is just a concept. And it's challenged basically by 2 dimensions. And we have heard very nice talks about the first dimension, which is a dynamics dimension. And this means we really have a switch or flip-flop of phenotypes. And I don't want to talk about this because that's not my title, right? I just want to share with you one, and I hope this works if I click in here, one patient from our registry, because honestly, I was never 100% convinced until today. We saw a lot of pictures, but I thought, okay, maybe it was a misdiagnosis, maybe it was an overlapping phenotype. I don't really know, right? Usually you see blurry pictures, but this is a patient that prospectively received an interleukin-13 therapy in this case. You see him at the left-hand side and then developed the lesions at the right-hand side. It's a very, very clear picture, let's say, of atopic dermatitis and psoriasis, and it is 100% at the poles of the diseases. It's not something which is overlapping. Okay, but I mean, this is not my topic anyway, right? My topic is the second dimension that challenges the concept of stratified medicine, and this is overlapping phenotypes. However you may call it, but we all do know them and see them in our daily clinical practice. And I have to say, I'm in this field for 20 years. I see quite many patients, but I would really not dare to say in these palmoplantar diseases whether this is a dyshydrotic eczema or palmoplantar psoriasis. Sometimes you have a clue and you say, okay, it's more this and more that. And then you ask other experts and they say, no, these are absolutely not our clues. I go for vesicles. No, if I see a pustule, then it's absolutely clear. It's sharply demarcated. It looks a little different, right? Whatever hyperproliferation, squamous look different or whatever. I can't do it. Similar here, seborrheisis is a nice term which was shaped. Psoriasis of the scalp, we just heard about it. Seborrheic eczema, what is it actually? If it's in the ear canal, like this minimal dermatosis, patients have a psoriasis history or whatever. And then we do have these patients. This patient has a psoriasis for 50 years, right? 50 years. And now he's old. And he has a diabetes, he has kidney problems, his skin gets drier and starts to itch, so he scratches, and you see around the psoriasis plaques, he now develops this kind of eczema lesions, right? Of course, there are also other aspects where differential diagnosis is super hard for me, at least. Very early mycosis fungoides. And just to be clear, this is the mycosis fungoides, and this is the nummular eczema, right? It's very hard for me to identify. And then this whole aspect of pustular diseases with all these nice names like Sneddon-Wilkinson or whatever you may call it. What is it? I have no clue, right? So this is what challenges us in daily practice. And now the question is, how can we translate and adapt this concept of molecular medicine in this context of blurry and overlapping diseases? And there are basically 2 answers to this. This is a very nice work done by Michel Gillier in Lausanne, now a little more than a year ago. And what he did was to define modules. Now you already see the problem starting. We called it immune response patterns, others call it signatures, cytokine signatures, HAPs, or modules, right? But whatever we talk about, it's pretty much the same. This is the type 1 immune response pattern. Every dot is a point, and you see here that by defining by nanostring a certain number of genes from lesional skin, Michel was able to clearly separate diseases. And here we have the lichen planus disease, which we know is a prototypic type 1 disease. Th2 would be atopic dermatitis, Th17 psoriasis. Nothing new so far. He also defined neutrophilic dermatosis and eosinophilic ones like the Wells syndrome, and type 1 interferon, which would be cutaneous lupus. So it is possible to measure them in a nanostring basis, and this is also something that now special centers in Europe started to do. And the alternative is my personal conflict of interest, is a lab-on-a-chip system, which is run by Dermagnostics, which is not really a startup anymore, but really starting up, let's say, with a fully automated test now with more than 50 customers, mostly in Germany and Europe, but soon to come also, I hope at least to the US, where we have either scraping or paraffin-embedded skin, which is inserted into this kind of disc system that you see here, and that disc is inserted into a player, and then fully automated you get molecular diagnosis. So you just have to press one button, and then you get deparaffинization, single-cell suspension, isolation of RNA, and real-time PCR, which is then read out by an optical system here in the player, and you have the result of this molecular analysis within, at the moment, 2 hours, but potentially in the future, much less so. If you want to see how this works, you are warmly invited also to watch this video. So this is a lab-on-a-chip system that already works, and it's approved in Europe at least, to differentiate exactly type 2 from type 3 diseases. So psoriasis-like from eczema-like diseases. And here you see some of these interesting pictures that we all know from melanoma and nevi, right, where artificial intelligence got big, and we have seen that it's better actually than the individual clinicians. Also here you see these are individual clinicians, and some of them tend towards the diagnosis of eczema, others tend towards the diagnosis of psoriasis. Overall, you have a pretty stable and interesting and valid, robust signal by this test, which gives a clear improvement in specificity and sensitivity. The question is then, what's your readout? What's the gold standard if you claim to be better than what's currently there? And the best readout that we identified so far is actually response to a specific therapy, right? If something responds to IL-13 or dupilumab, we would call it eczema. And if it's responding to IL-17 or IL-23, we say the ground truth, the truth is psoriasis. Now this comes again from the dermatopathology where there are certain tests, and now since 1 week, this is why I'm so proud, we have this very small scraping tool, 0.3 millimeter. We borrowed it from ophthalmologists, and we scrape a little bit, and we can really do this now in private practices and offices while the patient is in the waiting room. This test system runs, and we get that kind of information. The question is, how useful is that kind of information? And let me go back to the work of Michel Gillier, actually, which has two very important insights, I think. The one is, what he did here was to test like 80 or 90 patients that came into his office with a typical disease. So the clinician said in blue, these are atopic dermatitis patients, and in green, these are psoriasis patients. The yellow one was suspicious to have lichen planus-like reaction. And in all these patients, he did this kind of immune modules that I have shown you before in the nanostring-based analysis. Now, if that matched, and that was in the majority the case, the patients had an 81% chance to respond. That means even if the molecular signature matches the clinical diagnosis, we do not have 100% response rate. There are other factors that play in here, which may be pharmacogenetics, dynamics, whatever, compliance. But if they didn't match, then the patients did not have any chance to respond, which kind of makes sense. Interesting is that this was the case in almost 10% of the cases. So the clinicians were sure, and they are good clinicians in Lausanne, right? They were sure about the diagnosis. Molecular modules were different, and these patients did not respond, but when he switched them, the patients had a chance to respond. Another example why we think it's relevant is not only the clear patients, obviously, but also these overlapping phenotypes. And this is a patient from our study in Freiburg, and a patient where we had this initial clinical diagnosis, psoriasis, did not really respond, but what's more important here, I think, is we gave it to dermatopathologists. And also here, if you ask dermatopathologists, the way that they diagnose is pretty subjective, so they would not give us all the same result, right? In the end here, it came out this is not really psoriasis in the diagnostic testing, and we have another test now which identified this to be an early MF, and this patient really got a severe MF nodula in the coming month. So finally, and this is the core of my presentation, what is about mixed phenotypes? Is it good to have these diagnostics, or don't we need it? And what are mixed phenotypes? And let me put you here this example of nummular eczema, which is kind of an overlapping phenotype, right? You see it here. It's sharply demarcated, mostly occurring in elderly patients. It has these serum crusts, but then it also comes with neutrophils and staph aureus, so it's in between psoriasis and atopic dermatitis. And I think the main message is it's in between psoriasis and atopic dermatitis from a clinical point of view. And if that is the case, and I think the majority of you would agree, then it's usually also the case in histopathology, right? Also, histopathology would not give you a very clear-cut result. Otherwise, it would be strange, let's say. And the problem is, also from a molecular point of view, it's the same thing. That means nummular eczema has a lot of IL-13, type 2 signature, right? Much more than psoriasis. But it also has a lot of CXCL8 and interleukin-17, much more than atopic dermatitis, which explains why we do see neutrophils frequently in nummular eczema. So what we see is also seen by the dermatopathologist and relies on molecular disease. But still, molecular diagnostics can make a difference here. And if we use this dermagnostics kind of system, then nummular eczema is identified in by far more than 95% of the patients as a clear type 2 signature. And the question is then, what happens if we treat it with type 2 biologics? And here, and soon there will be a clinical study coming out, but here is just one of many case reports and case series published. And we do know that dupilumab works in nummular eczema as good as it does in atopic dermatitis from these sporadic cases. And the thing is, if we treat with dupilumab or IL-13, then also the neutrophils go down, right? It's clearly indicating that even in overlapping kind of phenotypes, we have a dominating immune response. And if that dominating immune response is treated with a specific therapy, then also this epiphenomenon, in this case of type 3 immunity, CXCL8 and neutrophils, go down and the lesion clears fully. And that's a clear difference to this dynamic state where we have a flip-flop. It's an overlapping disease and with one clearly dominating pathway. And the same is true for eczematized psoriasis, just the other way around. Here, IL-17 plays a major role, IL-17C, but also IL-17E, which gives us this typical overlap according to eosinophil granulocyte infiltration, right? But if we treat here with interleukin-17 or 23 inhibitors, the lesion fully clears away. The skin stays dry, but it's not inflamed anymore. There are no eosinophils in there anymore. So to summarize, I think this concept of stratified medicine really has established quite well. And we do know, and we have heard that numerous times today, we will hear it numerous times in the coming talks, type 2 eczema, type 3 psoriasis. But this is challenged either by this flip-flop phenomenon, dynamics of the disease, or by overlapping phenotypes. But if we have overlapping stable phenotypes, we may identify the driving dominant immune response or signature or module, however you call it. And if we treat that specifically, we have a very good chance that the lesion overall would improve. So there's no need at all to go back in these patients to systemic steroids or cyclosporin. We have to identify, and that is where molecular diagnostics is really helpful, the dominating underlying immune phenotype, and can then still treat these patients specifically. Thank you very much for your attention.
Thank you so much. Why don't you have a seat over here?
Yeah.
We have a chair for you, and unfortunately, we only have one of the speakers for this session here to answer questions, but others can also chime in. So I would invite anyone who has questions for this particular session to come up to the mic and go ahead and ask them to Kellyanne or Andy.
You go to the mic.
You go to the mic? Thank you.
Yeah, unfortunately that's the case. It's super frustrating, I think. But then I look at oncology and I'm really happy to see that checkpoint inhibitors against PD-1 also work better if we have a PD-1 level from the beginning, right? And it's just the same thing. That's the only reliable factors that allow us to predict is positive family history or own history in the past. And I fully agree, probably it's like it can be genetics and then there's an environmental influence. And the best treatment we do know of highly active psoriasis is highly active eczema and the other way around, because IL-4 works very nicely in psoriasis. Interferon gamma may work at least to some extent in eczema. So yes, unfortunately, that's the best predictive model. And then obviously what happens is most likely that memory cells are silenced in the skin. They are autoantigen specific, and then there comes a second hit, environmental trigger, and that allows them to re-exacerbate the other disease.
Hi, thanks. Mike Arden-Jones, UK. Yeah, I think I've heard you speak before, actually, about how we've been a bit disappointed about the utility of biomarkers in AD and probably psoriasis as well. So it's kind of slightly surprising that the molecular diagnostics is so useful. Do you think that perhaps it's because of our clinical sort of determinations in terms of the biomarker searching has not been perfect, and that's probably why we haven't found these endotypes we've known perhaps might be there?
Yeah, absolutely. I fully agree with you, right? I think what we did, first of all, was always to try to squeeze biomarkers into our way of thinking. They should fit to what we think rather than identifying biomarkers that would teach us new things, right? So that's kind of this approach. And the second thing is, I think the granularity of the clinical data that we had to train algorithms to identify biomarkers are just by far not enough. So we need to get much more granular to really know what we're talking about. And we cannot do that using a SCORAD or EASY and a PASI on the other way. I think we need high resolution clinical images. We need to train large vision models, use agentic AI, right? So the granularity just has to get better. It's not about the algorithms, it's about how we feed them in.
Well, there are people standing up there. Let's let them ask their questions. And then, Andy, the microphone's working now. Go ahead.
Dr. Sri Kumar from Dubai. So I have seen quite a few facial erythemas in atopic patients treated with the biologics, unlike the JAK inhibitors. Almost all of them. I would say not just dupilumab alone, even lebrikizumab I have seen. So my question is this a psoriasiform reaction? And if so, why is it specific to the head and neck area, face? And is there any explanation for, is it the Malassezia and the other Demodex story only a reflection of our thoughts due to the location of the condition and the erythema, and which came first?
So head and neck associated dermatitis, which worsens or de novo exists, exacerbates under dupilumab treatment. I don't know, somebody else wants to answer. I mean, what we know is that there is a more Th222 signature, right? This is work from Patrick Brunner and the Vienna group. And most likely it's really associated to Malassezia, not to Demodex, but to Malassezia. There are reports that azoles, antimycotics may improve that condition. However, this is highly controversial. I don't really think it's understood fully yet, but I wouldn't argue that this triggers a psoriasiform reaction. I rather think it's really triggered by the environment and microbiome, mycome, whatever, but this is just my personal opinion. I don't have a full clue here. Anybody?
Thank you, David Cohn from New York, and I really want to thank the IAC and the IPC for putting this together. It was an amazing meeting, and Killian, you're right, it was really not just being in the audience. Listen to the lecture, right, and have you put that together. I was intrigued, if not confused, by something you said about dermatitis. Did you give us the impression that there was some Th17 involvement because you saw the neutrophils there? And I just wonder if the amazingly exudative disrupted epidermis is not responsible for that neutrophilic infiltrate rather than it being a true psoriasiform phenotype of some sort.
I couldn't agree more, and probably the mechanism here is that these Th17 cells that actually really go into the skin, they migrate there, they are most likely reactive to Staph aureus. So it's exactly as you say, right? And that's also why the disease gets better when we treat with IL-13 or IL-4/13 inhibitor, right? That's the reason. So it's not an autoantigen-driven process by Th17 cells. The dominant response is the autoantigen of the Th2 immune response, and you have the epiphenomenon of Staph aureus-specific Th17 cells, secondary to exactly what you say, scratching and exudation and Staph aureus over-colonization.
This question a lot, but I don't know if there's data, and that is, do you think that there's more psoriasis and psoriatic arthritis-like reactions in patients treated with dupilumab, where you're blocking two Th2 cytokines versus a selective IL-13 blocker? Do you think Dupi is more shift compared to selective IL-13 blockade?
from a mechanistic point of view, I could not explain why, honestly, because I don't see that IL-4 plays a major role in differentiating T-cell immune responses, right? I think there IL-13 is the dominating and most important cytokine. So that's the, let's say, mechanistic kind of explanation. I think when it comes to epidemiology, the problem is, in this case, that, I mean, 80% is dupilumab, right? So obviously we see many, many more cases under dupilumab than under Labri or tralokinumab. But we do see them under IL-13 inhibitors also. So I at least think that from the mechanistic concept, IL-13 is the relevant cytokine, and I don't really think that IL-4 adds a lot to the game. But again here, I mean, I don't want to pretend in this audience I'm the expert on this topic.
Sounds good.
Okay.
I think it's how strongly you block T2. So do you block more effectively T2, so you shift more. That's my idea.
Well, we probably may see that with the upcoming therapies, right? And there will be quite some data shown here at the AAD about this more specific, higher dosing, half-life time extended IL-13s, for example. So if your theory is correct, which is absolutely possible, then we should also see this as a higher rate under this even more efficient, potentially more efficient IL-13 inhibitors.
Yeah.
Okay, well, thanks, everybody. I think we're going to just keep moving on to the next session since we had our break already. And this next session is on TNF-induced skin eruptions in patients with inflammatory bowel disease. So we're flip-flopping from eczema to psoriasis and the problems now that we're seeing with the anti-TNF alpha-induced skin eruptions. And we're going to move on, unfortunately, one more last pre-recorded talk, once again because of issues with travel. And this is from Dr. Lev Pavlovsky, who's a clinical associate professor of dermatology at the Sackler Faculty of Medicine in Tel Aviv University. He's also director of the psoriasis treatment unit and outpatient clinics in the Division of Dermatology at Rabin Medical Center in Petah Tikva, Israel. His clinical and research expertise lies in immunobiologic therapies for psoriasis, and he has served as principal investigator in numerous international clinical trials in this field. He's authored more than 60 scientific publications and was contributing author of the Israeli Clinical Guidelines for Psoriasis Treatment. His primary research interests include inflammatory skin diseases with a focus on the immunopharmacology of psoriasis, and he is an IPC counselor. So let's go ahead and hear what he has to say.
Hello, thank you for the kind introduction. I would also like to thank the organizers from IPC and International Exam Council for inviting me to give this lecture. Very gratefully, due to the current situation in our area, I cannot be there in person, so you will see the lecture by video. My conflicts of interest. In the lecture, we will cover epidemiology, clinical presentation, differential diagnosis, and treatment approach to anti-TNF alpha-induced skin eruption in patients with inflammatory bowel disease. The term most often used in the literature is paradoxical psoriasis or psoriasiform lesions due to anti-TNF therapy in IBD patients. And this clinical phenomena is relatively common, observed in around 6% of patients treated with anti-TNF for IBD. And most common medications are infliximab and adalimumab, because these are most common medications used to treat IBD. There is probably genetic susceptibility. Recently, a paper was published on interleukin-23 receptor polymorphism as a possible genetic background for these rashes. Interestingly, the time lag between starting anti-TNF and developing of skin disease vary from 1 month to several years, with a mean time of onset of 11 months. I will not go in details to mechanistic approach because there is, I'm sure, an excellent lecture by Professor Gudjonsson in this symposium, but I would like to say that the main cytokine of a disease is type 1 interferon. What about clinical characteristics of the disease? Actually, most of the patients don't have not personal and not family history of any dermatosis, not psoriasis, and not atopic dermatitis. And distribution of the rash is, as you can see on the scalp, limbs, but with relatively common locations like palmoplantar disease, face, and genital lesions. And I will show you examples. The morphology of anti-TNF-induced skin disease is mostly psoriasiform, but also eczema-like or eczematiform. And actually, it is not that easy to define it, as you will see in their following examples. But classical rash, as you can see here, is a rash of well-defined erythematous plaques with scales, which actually resemble psoriasis, but these are not lesions of classical psoriasis. This is example of much more dermatitis-like eruption in 86-year-old female disease with Crohn's disease, treated with infliximab. You can see signs of scratching. And another patient with Crohn with adalimumab, again widespread rash, not itch at all, more resembles psoriasis, but again, this is not a classical psoriasis. Histopathology. Histopathology reflects what we see clinically. As you can see here, this is prominent psoriasiform epidermal hyperplasia with maybe some degree of spongiosis and numerous eosinophils in the dermis, which reflects, of course, clinical appearance. As I said before, scalp and face are relatively common, and here you can see a postauricular fissure, which is not characteristic for scalp psoriasis. This location, of course, is common in scalp psoriasis, but not the fissure. Facial disease, as you can see here in this young man with Crohn on infliximab, with secondary infection prominent on the face and in the external ear canal. And in these cases, it is almost impossible to treat the infection with antibiotics without treating underlying inflammatory disease. Perianal anogenital disease is common, especially in patients with frequent diarrhea and the use of frequent wash of the area and use of topicals. And here is an example of prominent psoriatic involvement of perianal area. Palmoplantar disease is common, as you can see here, and palmoplantar pustular disease is very common, much more common than in idiopathic palmoplantar pustulosis, which is a rare disease. Another difference is that in idiopathic palmoplantar pustulosis, most of the patients, or almost all patients, are smokers. But in these IBD patients with anti-inflammatory, with anti-TNF-alpha induced palmoplantar pustular disease, not all of them are smokers. And there's another example of severe plantar pustulosis in patient on infliximab. One of the most important and distinct entities in these patients is inflammatory alopecia, which is very unique for this disease, and we don't see it not in scalp psoriasis, not in atopic dermatitis involving the scalp. As you can see here, this is prominent inflammation of the scalp with alopecia, and in these cases, the alopecia is not permanent after discontinuation of the TNF, and in most cases with appropriate treatment, the hair will regrow. Another example of is inflammatory alopecia with secondary infection, and again, the antibiotic treatment will not be helpful without controlling underlying inflammation. And again, complete regrowth of hair. Another example of scalp disease with secondary infection and face involvement. On histopathology, we can see psoriasiform epidermal hyperplasia with peribulbar chronic lymphohistiocytic infiltrate and miniaturization of hair follicles. What about differential diagnosis? Well, one of the entities that can mimic this disease, or disease that mimic the entity, is mycosis fungoides, most common form of cutaneous T-cell lymphoma. As you can see in this example, a 39-year-old with a male patient with Crohn's disease on adalimumab, and you can see these plaques with follicular accentuation, palmoplantar keratoderma, and inflammatory alopecia, and on histology, epithelial tropism of lymphocytes. These lymphocytes are CD4 positive, CD8 negative, and CD7 negative, and T-cell receptor arrangement is polyclonal. You can see that there is not prominent cellular atypia of the lymphocytes, but again, it may be in the case of mycosis fungoides, but the clinical course is completely different. In this case, adalimumab was stopped. The patient was switched to Stelara, which is not known to be a treatment for mycosis fungoides, with complete resolution of the rash. Another differential diagnosis of inflammatory alopecia is alopecia areata, which is also reported in patients treated with anti-TNF, but differential is easy even on the clinical background because you can see there is no inflammation of the skin. This is a very unusual case of a young female patient with Crohn's disease on adalimumab, inflammatory alopecia, and the most prominent feature was in nodules. You cannot see it good on the picture, but if you when we touched the scalp, it was many painful inflammatory nodules, and you can see on the right picture psoriasiform scalp eruption with post-auricular fissure. The key for diagnosis in this case was the anamnesis that husband of the patient has tinea on his face and scalp, and the fungal culture was positive for trichophyton tonzurans, and she was treated with antifungals with complete remission. What about treatment approach for this disease? Well, discontinuation of anti-TNF is required in around 12% of patients with TNF-induced psoriasiform eruption. And switching within class will be not helpful in most cases. Early switch to ustekinumab and ustekinumab. For many years, it was the only option to treat Crohn's disease and psoriasiform eruption secondary to anti-TNF because it was the only medication that was effective for skin and registered for Crohn's disease, indicated for Crohn's disease. But today there are other options. And scalp location is independently associated with less remission of skin. In other words, inflammatory alopecia is a reason to discontinue anti-TNF and usually to start another treatment, as I will show you in two cases. The first one, 21-year-old female patient with Crohn's disease on adalimumab, and she was presented to our department after 9 months on adalimumab with complete remission of Crohn's disease. And the rash, as you can see here, which could be, let's see, eruptive psoriasis or, as I judged at that moment, not very severe psoriasis from eruption secondary to anti-TNF, of course. And because she was in remission for Crohn's disease, we tried to treat her Crohn's disease and continue adalimumab. So we started topical corticosteroids and phototherapy. Unfortunately, severe inflammatory alopecia developed. And of course, at that moment, we discontinued adalimumab and started ustekinumab. It was not helpful. And as you can see here, it was a severe palmoplantar disease with nail involvement. Actually, she was on a wheelchair in this visit. So we added cyclosporine. And on combination of ustekinumab and cyclosporine, you can see hair regrowth, but not good enough response of palmoplantar disease. So almost more than 1 year of disease, we switched her to risankizumab. And as you can see, it was a complete remission of skin disease, all the domains, hair, palmoplantar disease, and again, Crohn was in complete remission, but again, 1.5 years of suffer. Another example, 23-year-old female patient, just postpartum and breastfeeding, Crohn disease since age of 14, cystectomy 10 years ago, 2 years on adalimumab, which was discontinued due to new onset psoriasis, diagnosis which was done before we met the patient, and then ustekinumab and vedolizumab with inadequate response of Crohn disease, and since 2023, infliximab. On infliximab, she developed terrible psoriasiform and eczematoid skin disease with secondary infection, genital involvement with, you cannot see it here, but believe me. So we stopped, of course, infliximab, and at that time we already had risankizumab, and risankizumab was initiated. But as you know, risankizumab is given intravenous initially in Crohn, and after this IV induction, no improvement. So we started with prednisone, and when we tapered prednisone, cyclosporine was initiated with some improvement, but again, terrible disease and secondary infection, and all the antibiotic trials are useless. And for that time, we got Rinvoq. And after 1 month on Rinvoq, it was complete remission of skin disease, and Crohn disease was in remission all the time. So we and the patient were very happy for her. But then on November, she was planning a new pregnancy, and we had to discontinue upadacitinib and restart risankizumab with hope that this time the skin disease will not relapse. But then, just 1 month after discontinuation of upadacitinib, of Rinvoq, new psoriatic scalp lesions appeared, and then skin rash. So now she's almost 3 months pregnant and treated with a combination of Skyrizi and cyclosporine to control the skin disease. So, to summarize, patients with mild disease can continue anti-TNF therapy with appropriate dermatologic management. Severe or refractory disease and special inflammatory alopecia require discontinuation of anti-TNF, and in most cases, switch to another treatment. What treatment to switch? I think here is the main gap, because we don't have the, at least now, not standard diagnostic criteria and not personalized treatment pathways, which we can choose right right patient, right treatment for the right patient. And of course, optimal care requires multidisciplinary management, individualized risk-benefit assessment, and close monitoring of both disease, skin and IBD. So with that, I would like to thank you. And you can see here, thank you, written simultaneously in Hebrew and Arabic. I think this day, this is self-explanatory. And with this hope for a better future, I would like to thank you again.
Thank you, Lev. Again, he's not actually here, but so the miracle of technology. So our next speaker really doesn't need a lot of introduction, and that's Amy Paller. She's an IPC and IEC counselor. She's been one of the household name dermatologists for decades. She was my mentor, still is, over the last 25 years or more. She's been president of multiple organizations. And we're delighted to have Amy here to talk about what else other than the clinical approach in children. Thank you, Amy.
Thanks, Alan. So we've seen lots and lots of cases today of both directions, with the psoriasis developing, most recently discussed from TNF-alpha inhibitors. But we haven't seen a single patient presented who's been under the age of 18 that I can remember. So it will be my job to bring us back to the fact that this can also occur in children. And I will say it can go both ways. We've also seen patients on dupilumab who have developed psoriasis or whose psoriasis has been unmasked. We'll focus here on the anti-TNF-alpha induced skin eruptions. So it's really very similar to what we were just talking about. There is a variety of epidemiologic studies out there. They range in from about 4.6 to 13.6% of those with IBD, but the majority of those with inflammatory bowel disease who are children, we're talking about these studies having more than 10%. So perhaps a little bit higher in children with IBD than what we even see in adults. Lower percentages in juvenile idiopathic arthritis. A reminder that psoriatic arthritis in children is within the category of juvenile idiopathic arthritis. And then when we think about what we see in terms of percentages who have certain diseases, in my experience and what's in the literature, more than 90% of what we see that comes in with this disorder are children with inflammatory bowel disease, and particularly Crohn's. But we do see it as well, not just in JIA, but also chronic multifocal recurrent osteolytis. We've seen a few patients with that, and other disorders that have been treated with the TNF-alpha inhibitors. In pediatric patients, the median age is about 14 years, and there's a range of time from the initiation of the inhibitor to the development of the psoriasiform dermatitis of 14 to 34 months. But once again, it does take time for this to develop. There was a study several years ago suggesting that at least concurrent methotrexate did not reduce the risk of occurrence. And in children, where we have more limited armamentarium for treating in general, the most commonly associated medication is infliximab, and to a lesser extent adalimumab. There have been rare reported cases with certolizumab, golimumab, etanercept, but these are not used as much, of course, in children either. As has been said repeatedly, these are patients who tend to do very well for their underlying disease. So if we think about Crohn's, they're doing really beautifully with Crohn's, no effective response. 92% in a large study that we recently completed had an excellent response for their primary disease. So that translates into the fact that families do not want to stop the medication that they're on. It's the last thing. They're very worried even about trying to do that, despite the fact that the child may have this eruption that can be quite uncomfortable. So all of these are features in children. Now, many children have multiple sites, but overall, the experience is that it's typically a more limited body surface area than what we see in traditional psoriasis. There's also tend to be less distinct plaques. Certainly in my experience with children, more oozing and crusting, more Staph aureus colonization. The most common site that we see is the scalp and the postauricular area. As in pediatric psoriasis, a very common site. We know from our work with the IPC that we're seeing scalp psoriasis much more often in children than what we're seeing in adults. Recent studies suggesting about 80%. More inflamed, more alopecia. We just heard from Lev about it not usually being cicatricial, but I have seen one case that was quite severe and can scar. So we do want to be very aggressive in treating scalp involvement. I'm not going to show you any case series or specific cases, but I think you can look through this series of children here, as I'll show you more pictures showing the scalp involvement, sometimes oozing, crusting. There's that fissure behind the ear. We just heard very frequently we'll see fissuring here. We're seeing some fissures. We see periorificial involvement very commonly on the face, as you can see in this child, or these two children here. Some other clinical features. Trunk, not so much. I'm going to give you an example with a small pilot study we did, but sometimes they are on the trunk, and they can be these smaller guttate lesions, but very often on the hands, on the fingers, on the feet, on the toes, involving the nails, sometimes with pustulosis. Some more examples of this in children. Knees and elbows, yes, we can see it there, but certainly not with the frequency that we see it in our typical plaque psoriasis in children. There have been many reports of these truncal follicular or sometimes pustular or punctate lesions, some examples in children shown here, and some other examples here, both cases of teenagers. So I think one of the problems is just recognition of this, and I'm going to raise this in the context of the fact that psoriasis is very common in adults. It's much less common in children. So primary care providers often don't recognize psoriasis. And similarly then, are we seeing this and recognizing it when it occurs with the TNF-alpha inhibitor-induced disease? And fortunately, this is now common enough that our pediatric GI services, our pediatric rheumatologists, clearly think about the possibility here when they have their patients on these TNF inhibitor-induced, when they have their patients on TNF inhibitors. But what they sometimes can't know and that they're not confident of is this caused by the TNF inhibitor, or could this be that the patients just develop psoriasis because they know that there's an increased risk of developing psoriasis in children with IBD, with JIA, and they're not well trained to really understand how to differentiate. So this has been a problem, and that's of course compounded by the fact that psoriasis in children doesn't always look like psoriasis in adults. These can be thinner scales, they can be more indistinct plaques, there's more facial involvement, there can be scalp-only involvement. Sometimes patients have what looks like psoriasiform dermatitis, and we call it psoriasis without these TNF inhibitors, and there are certainly many patients that we see who have classic psoriasis and classic atopic dermatitis. And then of course we have to think about the differential with all of these patients, and very commonly what is really psoriasis is mistaken for atopic or nummular dermatitis, for seborrheic dermatitis, for infections that are tinea or candida or contact dermatitis. So this becomes a problem of recognition, and they'll send to us because they're really not sure what's going on, and nobody wants to stop that highly effective TNF inhibitor. So we need better education, and we need to think about, are there any biomarkers that we can help with making these decisions and making them quickly to help know, do we have to stop this? How do we treat this? So first of all, are there biomarkers to distinguish psoriasis in children from the TNF inhibitor-induced psoriasiform dermatitis? And there's really been very, very little work done in this area. There were some older studies coming out of the GI literature finding some IL-23 receptor polymorphisms conferring an increased risk after infliximab in children. There was another study looking at some rare alleles associated with increased risk and a few other genes, but it really hasn't gone very far in helping us. Now, we're going to hear very quickly more from Johan Gudjonsen. He's going to tell us a little bit about the landscape here molecularly. And these studies have come from studies in adults. They have looked at mRNA expression. They extracted these from biopsied lesional skin. Now, I'm a pediatric dermatologist, and some of you see a lot of children. You know that I don't think there's a child alive who wants us to do a biopsy on them. So to try to look at that is going to be a real problem. So I'm going to talk a little bit about how is TNF inhibitor-induced psoriasiform dermatitis treated in pediatric patients. And I will say it's quite similar to what we've been hearing in adults. Is the response any different? And then can we use any non-invasive means to predict? So this has come out in terms of an algorithm for management, and very simply I'll just say that this is what we do. If it's a milder psoriasis, we're certainly not going to say to the parents, you have to stop this TNF inhibitor that's been so wonderful for your life. So we will move forward with topical steroids. We might add in topical calcineurin inhibitors, particularly for facial and more sensitive regions. We might use vitamin D analogs, even topical retinoids. If they're eczematous and weeping, we might think about secondary staphylococcal infection, and we might start something that's anti-staphylococcal, whether we're talking about mupirocin or let's say in Europe, fusidic acid, or even a systemic anti-staphylococcal drug. But when we look at those patients with mild or moderate involvement who we've treated only with topical, only 15% of them will clear with topical therapy alone. 63% will experience partial clearance, and depending on how much of a problem this is, you have to make that decision about, is that good enough? Because if not, then we have to treat, as we think about, with moderate to severe psoriasis and these psoriatic involvement. For example, we talked about involvement on the scalp being something that may be pushing you towards being more aggressive with your treatment. Now, again, the TNF inhibitor is being required to control that underlying disease in most of these cases. I said 92% in great control. So what direction do we want to go? Well, in some cases, we might start by increasing the immunomodulation. We heard this already. We're going to add in, and we heard this both whether we're talking about getting more of this eczematous or more of the psoriatic, depending on, doesn't matter what you're on, we might just add an immunomodulator. So adding the methotrexate or the cyclosporin or the ustekinumab or phototherapy or acitretin. But in many of these patients, that's really not helping them sufficiently. So we might think about switching to a different TNF-alpha inhibitor. And in the past, this is primarily what we ended up doing. And in fact, in a pediatric study that we just did with more than 100 patients, the percentage of children, which was about 30% who did this, showed 82% of them improving by 3 months. So this is a viable option. But the problem is that some of these children, of course, were recalcitrant or their disease progressed, and also that as you follow these children out, 31% had recurrence of the TNF inhibitor-induced psoriasiform dermatitis at a median of 6 months. So maybe not the ideal direction to go. So increasingly, we have been instead stopping the TNF inhibitor and starting an alternative agent. And depending on what we're treating, obviously, we may go in different directions. So as I said, the vast majority of what we see is inflammatory bowel disease. And we've been starting most of these patients on ustekinumab with very good results. This has become the treatment of choice in pediatric dermatology for our patients, particularly with Crohn's disease, but also, for example, that can work well with junctional idiopathic arthritis. So I've listed up there some of the possible agents that we can be thinking about in terms of transitioning from the TNF-alpha inhibitor, and that usually actually takes care of it quite well. So how good are these for treating the underlying disease? We'll stick with Crohn's here and talking about that a little bit to just say that with alternative agents, and especially ustekinumab, more than 81% with Crohn's will clear or stay clear on their non-TNF-alpha inhibitor. This is a study here of 40 patients previously treated with TNF inhibitors, and 61% achieved clinical remission, a little bit harder with perianal disease. Also, it's been found that ustekinumab reduces the pediatric Crohn's disease activity index by more than 50% in patients who are resistant. So some information suggesting that this is a good direction to consider. And my own experience over the last year or so of working with our pediatric rheumatologists and our pediatric gastroenterologists is that they're pretty comfortable doing this, and it's been quite helpful for our patients. So this is what we found just very quickly, looking at these volcano plots, looking at psoriasis versus healthy controls in the group, a lot of differentially expressed proteins. No surprise here. We've got a strong Th17, Th1 signature, somewhat different proteins, a lot of the, again, the downstream ones, the chemokines being seen in that outer epidermal area, vascular remodeling represented by a lot of VEGF, and epidermal activation barrier remodeling, biomarkers, particularly TGF-alpha, seen here on the proteomics. Now, when we look at the pediatric TNF inhibitor-induced disease, we see, again, many differentially expressed proteins versus the healthy controls. Interestingly, if you look at the top 6 differentially expressed proteins, they were absolutely the same in psoriasis and in the TNF inhibitor-induced set. And we also saw other proteins that were very high, like your Th1 ones, CXCL9, CXCL10, also some chemokine like CCL22. And interleukin-17 was also high in this group. So we've heard this before. It's similar to the adults. They both show a psoriasis-type phenotype. Again, vascular remodeling, epidermal activation, and hyperproliferation. Same biomarkers here by proteomic. But we did have 19 differentially expressed in the TNF inhibitor-induced versus the psoriasis. And I just want to point these out because they suggest to us that maybe we could have an easy panel for these specialists in GI, our specialists in rheumatology, to be able to do something to try to help in addition to our clinical expertise. So we found 4 that we were particularly interested in that had in the highest group that were differentially expressed and higher in TNF inhibitor-induced, and these were the interferon-inducible protein, particularly HLA-DRA, a regulator of interferon expression CD200 receptor, 2 markers of immune cell infiltration, LSP1 and HCL1S. And then on the other side, we were particularly interested in, even though we can see it in both groups, much higher in psoriasis was the IL-17C as a marker for that. So a small sample, but maybe giving us the idea that we might be able to find a biomarker panel that would be very useful. So in conclusion, TNF inhibitor-induced psoriasis from dermatitis is a common complication for the TNF inhibitor use in inflammatory bowel disease, in particular in children. Non-invasive tape stripping or scraping in proteomics may distinguish a psoriasis from the TNF inhibitor-induced disease based on the biomarkers. Children in general may respond better than adults to topical intervention, but we often will need to discontinue their TNF inhibitor despite the fact that it is so effective for their disease, always a hard sell with parents. But switch to another inhibitor, often if it's a TNF inhibitor, can lead to recurrence. We talked about more than 30% with a median of 6 months. And ustekinumab has been our new treatment of choice for switching, best track record of change if another biologic is required. And I thank you for your attention.
Thank you for that, Amy. We're going to have some questions after the next talk. So it's a pleasure to introduce Johan Johnson as our next speaker. Johan's the Arthur C. Curtis Professor of Skin Molecular Immunology at University of Michigan. He'd be well known to everyone. He's an IEC and IPC counsellor. He's made many discoveries in basic immunity and genetics of psoriasis, and I think of him most for synthesizing really elegantly huge data sets and making sense of them, and some really elegant experiments. So we're going to hear from Johan now. Thank you for joining us, Johan.
Well, thank you for that kind introduction. I'm very excited to be with you this afternoon. So my talk is going to be focused on more of the mechanism aspects of paradoxical reactions and these iatrogenic switches. So these are my conflicts of interest. And before we kind of dive into the paradoxical reactions, I just want to kind of highlight, it's a beautiful perspective that my colleague Killian actually published in the European Journal of Dermatology and Venereology about now, 8 years ago. And it was really to kind of show you, how different inflammatory diseases really have different immune polarization patterns. And based on that, you're going to define these 4 major kind of polarization patterns. The pattern 1, which is like lichenoid Th1 responses, pattern 2, eczematous blistering Th2 responses, and then pattern 3, which was more psoriasis or Th17 responses, and then pattern 4, which was more fibrogenic or fibrosis driving mechanisms and granulomatous type inflammation. And you can see that in the graph there in the middle, that you can really kind of group different diseases based on the different inflammatory patterns. And why is this important and helpful? It's because many of the treatments that we have actually do overlap or are specific to specific immune and inflammatory patterns, like the JAK inhibitors for the pattern 1. There's more evidence for them to be effective in diseases such as lichen planus. The anti-IL-4, anti-IL-13, and the JAK inhibitors in the Th2 type immune response. You have a whole range in the psoriasis kind of a spectrum, and then you have much fewer still in the fibrotic kind of a space, but kind of growing evidence for the use of like JAK inhibitors in like granulomatous type inflammatory patterns. But it's helpful to also kind of think about the immune system as kind of a balance between different arms of the cytokine and the immune network. And here we have kind of these 3 different arms that we kind of think about: the Th2, the type 17, and type 1 inflammation. And I also want to kind of add in that also interferon type responses really kind of contribute and play a role in this kind of a balance between the different arms. And this really is this kind of a baseline immune balance. We see some evidence of all these different signals across multiple different inflammatory diseases. There are certainly some immune patterns that are dominant in a particular data set, but there's also evidence of small activation of the other one. So it really is this, even in disease state and inflammatory disease state, you really have a very delicate balance between different immune axes in these disease processes. And I kind of like to kind of highlight psoriasis as a kind of a good example of this, particularly given that there's so many different and diverse immune responses going on at the same time. You have, on one end, you have the type 1 interferon response that we have associated with both unstable psoriasis and triggering and onset of psoriasis. We also have type 2 responses involved around interferon gamma as kind of the key cytokine. And then we have IL-17 response kind of being the hallmark, the bullseye of psoriasis. And then in the epidermis, you have more of an IL-36 response that is really driving the feed-forward amplification of inflammatory responses in psoriasis. But these immune axes and cytokine axes really exist in balance in disease like psoriasis, where IL-17, based on all the clinical data that we have, is the key mechanism. But there's also contribution from the interferon and the IL-36 axis. So that kind of brings us into the paradoxical type reactions. So what are paradoxical reactions? So a definition of them, it's a development of a cutaneous inflammatory condition, usually during immunomodulatory therapy, that either is usually treated by the same class of therapy. An example of this is like psoriasis, like skin rashes that arise in patients being treated with an anti-TNF agent for inflammatory bowel disease that like Dr. Amy Pollard just showed you, or anti-TNF agents for rheumatoid arthritis. And then there's another mechanism that can kind of arise through compensatory immune pathway activation, that you're treating a certain condition and then it kind of shifts, and you kind of get a little bit of a different clinical phenotype arising in the same patient that you're treating for an underlying disease. But the significance of this is really that paradoxical reactions really illustrate that the inflammatory skin diseases are not driven by a single cytokine, by really an interconnected immune network where therapeutic blockade can reveal and activate latent inflammatory circuits. So really, paradoxical skin reactions really reflect this immune network plasticity. That's really what we're talking about. This was, I would say, a very important publication in the field. This was from Curtin Conrad. This was published about 8 years ago in Nature Communication. He was looking at paradoxical reaction, new onset psoriasis in patients treated for other underlying inflammatory diseases. And you see some clinical images there on the left with the histological features. And then if you're looking at the different kind of a shift in the immune response that is happening, and here it's being contrasted against what you see in plaque psoriasis, you're really seeing a few different mechanisms kind of getting activated. One of them is the type 1 interferon, interferon alpha, and interferon beta. You're also getting IL-22 responses, and then type 2 interferon, interferon gamma is really getting activated and more highly expressed. And accompanying by this is increased infiltration of a plasmacytoid dendritic cell, which we think of being the key and major source of type 1 interferons in inflammatory skin conditions. So if you're going to go back to the schematic that I had before in terms of that immune balance in psoriasis, what you're really seeing is both increased kind of relevance and impact of the type 1 interferons, the type 2 interferons, whereas the IL-17 response is kind of being practically the same. So it really is an interferon type shift that is driving the phenotype in that particular setting. What I think is also important to kind of appreciate is that there are many different types of paradoxical reactions. We have lichenoid forms of paradoxical reactions. So here we see this kind of a development of these purple polygonal papules with like an interface reaction and this beautiful sawtoothing on histology. And that really is that you're getting a Th17 to a Th1 kind of an inflammatory shift. You can also have these eczematous-like reactions where the shift is probably going the other way around. You're kind of getting more of a Th2 response at the cost of the other ones being either suppressed or less relevant. And then what we see quite frequently in the clinic is these pustular type of paradoxical reactions. We kind of get pustules often superimposed on the pre-existing skin lesion, and here the activity is really on the IL-36 axis being hyperactivated. So what I want to show you is it's kind of some preliminary data that we have been kind of working on also in the lab. And here we have patients that have been treated with anti-IL-23 and anti-IL-17 drugs for classic plaque psoriasis. And then they develop these kind of psoriasis-like skin reactions that are kind of more in keeping with like atopic eczema or dermatitis. And we've been using single cell profiling of skin biopsies taken from these individuals, along with spatial transcriptomics and immunohistochemistry for validation, and then kind of looking at the different inflammatory subsets and the shift in the specific immune population, contrasting the paradoxical reaction with your classic plaque psoriasis and atopic dermatitis. And when you do it like this, you have these four different kind of polarization kind of a pattern. You have your normal skin, you have your plaque psoriasis, you have your paradoxical reaction, and the atopic dermatitis. You can see the epidermal phenotype and how that's developed in these different clinical phenotypes. And then you can kind of look at the overlap in the gene expression on a global level between these different forms of skin inflammation. And when you look specifically at what's happening in the paradoxical reaction, you're really kind of getting activation of the innate immune system and neutrophil degranulation. And if you look at the biological mechanisms that are really shifting, you can see that there's actually quite dramatic shift in terms of what biological pathways and immune mechanisms are actually being activated. So here we see more kind of neutrophil-driven inflammation, but along with a Th2 immune response, and also activation of type 1 interferon responses. So you're getting like a mixed kind of inflammatory pattern that is still quite strikingly different from what you see in plaque psoriasis that is in the second row. If you look at what's happening in the skin, we are looking here at the myeloid and keratinocyte kind of a crosstalk. And if you look at PR, we're kind of getting a shift towards keratinocyte myeloid interactions, not quite to the same extent that you can see in atopic dermatitis, but quite significant compared to plaque psoriasis. And if we look at the different myeloid subsets in the skin, including these different dendritic cell subsets, the macrophages, and the dendritic cells, including plasmacytoid dendritic cells, we are really seeing activation of one of the TNF superfamily members, the tweak signaling, or TNF SF12. If you see what really is, where is the tweak kind of coming from? Here is like an in vitro study where we took LPS to activate the dendritic cells, and then with or without the presence of infliximab, an anti-TNF, and really having an anti-TNF in that system, you're really getting increased levels of tweak expression. So in this particular setting, TNF is acting as an anti-inflammatory, suppressing expression of this TNF superfamily members to kind of suppress inflammation. So we're seeing activation of like a myeloid keratinocyte crosstalk that is activated and increased in paradoxical psoriasis, and really kind of driving some of that inflammation. And you can see that also here by looking at the expression of the tweak receptor. You have the immunohistochemistry there in the panel on the left. Then you're looking at the positive and negative cells, kind of highlighting the expression of the receptor there in red. You can really appreciate very dense expression of the receptor in the basal layer of the epidermis, most prominently in atopic dermatitis, but more in PR compared to atopic skin. And you can also appreciate the density of the expression. So you can kind of tease that out of immunohistochemical kind of assessments. And then you can kind of look at the number of both the tweak, or cells that actually express the tweak, in the 4 conditions against one another, and also the tweak receptors. So you can see a very dramatic shift from psoriasis over to much more tweak, sometimes more or at least comparable to what you can see in atopic dermatitis. And if you look at the signal itself that is being activated by tweak, particularly in combination with IL-13, you can really appreciate this very kind of a dramatic signal where it's actually amplifying a Th2 signal, even more so than the cytokine can do itself. So it's a modulating and modifying inflammatory response in this particular setting. And here you can see also if you add in tweak with either IL-13 or IL-17, you're getting a pretty dramatic shift in the immunological response in keratinocytes, particularly towards interferon type responses. So kind of going back again to kind of the different kind of a clinical phenotype. So here we have like an eczema-like paradoxical reaction, but probably a more complex mechanism than what I showed you before. It's not just the interferons that are being activated. The upstream regulator of that actually is TNF superfamily member in this setting, the tweak signaling being a key driver. So really, it's additional pathways and cytokines beyond type 1 and type 2 interferons that really are contributing to these paradoxical reactions. And here we have identified tweak as one of the members of the TNF superfamily of cytokines, as a modulator of immune responses and a key driver of eczema-like paradoxical reactions in psoriasis. So really kind of going back to paradoxical reactions, so the key takeaway home point is that paradoxical reactions really reflect immune network plasticity and not drug failure in these diseases. And targeted cytokine blockade, whether it's TNF, IL-17, or IL-4 receptor, can unmask alternative inflammatory pathway and drive the inflammation in these diseases toward very specific inflammatory axis. And as I showed you before, with the psoriasis, it really sits within a dynamic immune balance centered on IL-17, but also interconnected with these other cytokine axes in the disease. And really therapeutic perturbation of this can really shift this balance, allowing compensatory activation of parallel pathway. For example, IL-17 inhibition can activate the Th2 or eczematous responses, whereas the IL-4 receptor blockade can really activate psoriasis form or psoriasis-like inflammation. And these paradoxical phenotypes really follow a predictable immune polarization patterns in these reactions. And the clinical manifestation usually kind of go with it. As you kind of get more of an IL-17 response in these reactions, you get more of a psoriasis-like phenotype. If you get more of a Th2 kind of response with or without in different responses, you're getting more like an eczema-like manifestation, and they map onto these different dominant inflammatory axes. So really, these data and the concept of paradoxical reactions really support a unifying model of immune switching across inflammatory skin diseases. So with that, I'll conclude, and I think we have a question panel after this.